Cécalo. Cécalo. Halo, cek. Sek.
हाँ पोडियम चल रहा है भाई तेरा। डीसी यहाँ पे जो दो HDMI फाइबर वाली है वो तो नहीं लगानी ना। हाँ वो तो लगी हुई दूसरी लगी हुई है। देख डीसी आ गई। नहीं लिया। ये ये दूसरी वाली है। ये मोटी वाली है। अभी खाली एक ही प्रेजेंटेशन आई है। एक ही आई है। हाँ ठीक है।
Good morning. Welcome to the Desire Hall. And I would like to request Dr. Rajiv Sood sir, Dr. H.S. Patel sir, and Dr. Sameer Khanna sir to please join the chair and start the session. Good morning.
So, good morning, everybody. Today's proceedings, we start with the one important topic which will be introduced by Dr. Bhatyal, and he will introduce the speaker also. Dr. Bhatyal, my co-chair, and Dr. Sameer, Sameer Khanna, they are with me to chair this session. And this is regarding recent updates in the management of carcinoma prostate. Dr. Bhatyal to introduce the speaker, please.
Good morning, everybody. This morning session is a very interesting session. And the speaker, Dr. Aditya Pradhan, he is a director and very senior urologist, uro-oncologist and transplant surgeon at BLK Super Specialty Hospital. He's got a lot of insight into the uro-oncology, and we are going to listen to him about the recent updates in the management of carcinoma prostate. Dr. Aditya Pradhan, please.
Good morning to you. I thank the organizers for giving me this opportunity to speak at the forum. I would like to clarify, this is not actually a recent advances overview, but basically it is ADT and what we know of agonists versus antagonists. So both agonists and antagonists have a role in therapy for a patient. And actually what we do, whether we do medical or surgical castration, depends a lot on where you're practicing. So let me just take us through the steps of what is the agonist antagonist. The slides are not moving up. Slides are not moving. Yeah, that's better. So we know that since 1941, since the time of Higgins, we know that ADT is actually the mainstay of treatment, and that stands true today also. We have in ADT therapy, we have actually had 4 ways of doing it. We used to do surgical castration, which is fairly popular even now, but being given up slowly because of better drugs availability and for the psychological disturbance that a lot of our patients have if you offer them ADT upfront. The earlier concept of maximum androgen blockade, where you add bicalutamide, this is actually almost given up. So on the whole, basically our therapy boils down to agonists versus antagonists, and that's what I'm going to talk about. Why are we giving ADT and what does it achieve? First of all, it reduces the testosterone, which is our aim. It reduces the PSA, so you know how you're going. And it acts to reduce the FSH independently. And an FSH which is reduced has a role in the progression of the disease, as I shall shortly go on further to tell you. The next step, the next is actually to understand how it works, an agonist, and then how does an antagonist work. So an agonist works basically by mimicking the action of GnRH, induces a surge, which then relies on the feedback to block further testosterone production by blocking the GnRH at the hypothalamic level. An antagonist actually does not have the surge. It directly produces a strong antagonism antagonistic action to GnRH pulse release. So these are the questions which you need to understand. Is an antagonist truly better than an agonist? If so, in what situations? What is the evidence? Is there clear and unequivocal indications for the use, and what is the future? I have told you this, that they are different in the way they act. So the effects which we are actually looking at is which is better on FSH and on testosterone levels. And how well does it do to reduce the testosterone? Let's look at the agonist first. So this is data which shows you that the lower the testosterone that you achieve, better is the outcomes for the patient. This has been well proven many times over. It reduces the progression, it reduces the survival. So your aim is actually to get the testosterone as low as possible, right? So what we have found is earlier we used to take 50 as the cutoff. If a patient's below 50 nanograms, we felt that this was enough suppression. Now we know that as low as you can is better, and therefore currently we accept that 20 is what you should be aiming at. So castrate should be as low as possible, preferably below 20. So if you take the how well do they work, all the agonists, whether you take goserelin or whichever is available in the market, this is what you achieve. Basically, in only about 26% of the patients is the testosterone higher than 50, but in 73 you achieve a level below 50. But if you look at the revised threshold and you see that it is only in the minority that you achieve that below 20 level. In most of the patients, in more than 70% actually, the levels are beyond 20. So your suppression is not very, very strong with an agonist. What about the antagonist? This is what you achieve. When you compare the two, you see first day itself, there's a sharp drop in the amount of testosterone circulating. And this compares with the flare, which actually comes up when you give an agonist. So this is a big difference. And beyond this, it is sustained. And therefore, when you look at the testosterone levels, it is actually very, very low. And therefore, it is a better suppressor for testosterone suppression. The other is, of course, the FSH. Here, you have the FSH shown, which has decreased from day one and stays suppressed throughout the period of his study. You achieve actually a 64 reduction in PSA, and it is sustained over the 3 months. The FSH is well tolerated, and studies have shown that FSH is suppressed even as far as 15 years. Bone markers, the serum alkaline phosphatase we were aware of, it is a marker for bone turnover that is also shown to be reduced very strongly with an antagonist. What about FSH? I mentioned that briefly at the outset. FSH is important. We pay less attention to it. It's time that we look at what FSH does. So if there's a high FSH, you have a direct correlation with tumor size and extension, cancer resistance development, proliferation, metastasis to bone remodeling, and the metabolic syndrome. So in fact, all the markers for progression of a prostate cancer are increased. Higher the level of FSH, higher is the progression. On the other hand, hormonal effects of ADT also we all know, hot flushes, gynecomastia, etc. So if your patient is on ADT and you are not paying attention to him, it's not the prostate cancer that will eventually kill the patient in 10 to 15 years, but certainly his cardiovascular disease will. How common is these comorbidities in patients with prostate cancer? This is a patient who is 60 plus on an average. So when you look at population-based studies, we find that more than 50% of patients have some underlying cardiovascular risk. So we need to look at cardiovascular health of a patient on ADT. And if there is cardiovascular disease present, these are studies which tell you how much is the morbidity. So you learn a 72% risk of a coronary event and MI and sudden cardiac death. So you have a very high chance that the patient in 15 years will die of some cardiovascular toxicity. FSH, what does it do at the level of the blood vessel? We are aware that the plaque which sets off the atherosclerotic cycle, the surface of the plaque has receptors for FSH and GnRH. A plaque which is stable has no real long-term problem. But the moment ADT is introduced, the instability at the plaque wall is produced because of a suppression in the FSH and the GnRH receptor, and that makes an unstable plaque rupture that leads to a cardiac event. As a clinician, how do I assess my patient? First is that when I see the patient and I'm concerned about his cardiac status, there are risk calculators available. One I have just shown. So you assess the risk factor and then take the steps necessary to reduce those risk factors which I have mentioned. There are some other disadvantages of internus. Well, they produce local injection, site pain. So it is important that you handle it carefully and do it yourself or get a trained nurse to do it. It is a monthly administration and therefore it is a cost also added to the therapy. So there are ways to reduce the injection site reactions, which I've just mentioned. And if you do it well, then by and large, less than 1% of patients will stop using the therapy because of this side effect. What about real-time data on clinical mortality? These are data from large studies. This was a very popular study where cardiovascular morbidity was seen in a large group of patients from 6 phase 3 trials. What they found was in over almost 1,500 patients, the toxicity was pretty strong with the agonists. And the comparison of agonists to antagonists showed a difference which was in favor of the antagonist therapy. A serious cardiovascular risk event occurred in almost 37 of these patients. And therefore, if you see the difference, it is halved when you give an antagonist versus an agonist. This risk starts right from day one. And if you serially calculate it over the period of study, the separation occurs right at the outset. So if you see overall survival is markedly different in 15 years for agonists versus antagonists. This is the difference which has been shown. So the summary of this data is that the relative risk reduction is almost 50%. So this is something which we cannot ignore. If you use an antagonist in 15 years, his risk of cardiovascular death or death from cardiovascular disease is halved compared to if you use an agonist. This is an updated meta-analysis of the same study. And over this period, they have found these results hold. There's lesser cardiovascular events and lesser overall mortality. There is one randomized trial on this subject done in a center in Israel by Mr. Markle. 80 men were head-to-head compared agonist to antagonist. And they also found in a randomized study, there's a 3% versus 20% risk reduction in cardiovascular mortality for patients on antagonist therapy. Today, we are not only restricted to an injection monthly. We now have HERO trial confirmed data from the oral agent relugolix. This was the phase 3 randomized study, which showed the efficacy of a single pill daily. Starting from day one, there's a marked reduction in the circulating testosterone levels. And therefore, relugolix was found to be effective. It is a game changer in ADT therapy. It's an oral pill acting from day one, and therefore has a lot of potential for us in clinical use. It improves patient compliance. It is a reduced cost attached to it, and you can use it very well for intermittent ADT. So, gentlemen, the implications are very clear. Antagonists have a clear lead over the agonist. Today's therapy is antagonist driven. Thank you.
Thank you, Dr. Pradhan. I have a small question. When you compare the surgical castration with the medical castration, how much time does it take for the testosterone level to come down to castrate level in all these three modalities?
So when you take surgical castration or antagonists, they are early. Within the day, the testosterone level drops. And agonist therapy takes up to 15 days to achieve the nadir. So there is a slower onset of action with the agonists.
Doctor, yeah. Dr. Aditya, you have related FSH with the morbidity and mortality by various mechanisms. When you do surgical castration, when impending spinal problems are there, collapse is impending or other problems are there, why we say that surgical castration is better, FSH is increased manifold after
So-
that.
So I think in the scenarios that you are asking, there is actually a need for immediate castrate levels. That you can achieve by either starting off an antagonist or doing a surgical castration. The risk remains of an FSH surge because you have reduced the feedback. So FSH surge is bound to be there. What we know is the FSH surges are highest with a surgical castration. So this we should be aware of because in India, we are doing surgical castration very commonly. We have never paid attention to what is the aftermath of surgical castration in the long term. And this is what data is telling us now. So as I was trying to say, your patient will survive prostate cancer, but he'll probably die of cardiovascular disease in the long term when you're looking at him 10 years down the line.
There was a meta-analysis and in that it was proven that cardiac events increase after surgical castration. But is there any attempt or effort when we are having this new data, updated data, that we recommend that it should be patient's choice and he should be warned about this after effect?
So I actually brought out that data, updated data. This is the one. This is the largest series ever published. This is Albertson's data from multiple centers. And what they have shown now is that once you are decided that a patient needs ADT, it is given that you should consider his risks. How do you consider it? You have to calculate the risk. There are risk calculators which are online available. You feed in the age, you weight, you look at his lipid profile, ECG, and then it gives you a score. If you have a high risk patient, it is advisable to consider this patient for antagonist rather than agonist therapy. So there is a way to go about it. The other thing obviously is the cost and the availability. This factor is probably going to be relegated to lesser importance when you have an oral pill available. So that's why I mentioned Relugolix, its availability would be a game changer for us.
So there are some trials with the Degarelix where switch is done from Lipride to Degarelix or
Yes.
an agonist to
Antagonist.
Antagonist.
And in those trials, it has been seen that some benefit is there.
Yes.
So do you think that such things can be done after surgical castration also?
Well, actually, once you've done a surgical castration, there is no reversibility, so to say. So where would you actually place the role for a
The
Degarelix therapy?
surge which
It would only-
FSH surge, which is going to be
Yes.
long lasting.
Yes.
So can we consider that if it is so important?
So if I've understood you correctly, sir, once you've done a surgical castration
Yes.
and he's reached CRPC levels, you're looking at the testosterone and
yes.
you find that there is a elevated testosterone. In this kind of a setting,
Elevated FSH. And
FSH is bound to be high.
yeah,
you're-
so should we address that situation for reducing the future comorbidities?
Our target of therapy is testosterone and FSH both.
That is immediate
Yes,
target.
that is our
for
target.
the CA prostate.
So currently we do not have any FSH antagonist, so to say. We do not have an antagonist to reduce your FSH level. It's the way that it is being reduced. Agonists are not going to reduce it. Surgical castration is not going to reduce it. Currently in our armamentarium, you only have an antagonist. I do not, at least I'm not aware that there is any drug which specifically attacks your FSH receptors. We don't have any. such drug.
Agonist will not change FSH. It will.
Agonist does.
Yeah.
Agonist, in fact, produces a FSH surge, which is very high.
FSH agonist will LH is reduced and FSH remains stable, almost stable. But after surgical castration, it increases.
So I'll just like to mention that the FSH levels, if you take how they differ between the agonist and
So
antagonist.
this is important question which I think
Yes.
when we are discussing recent updates, this should be addressed. And another is that FSH receptors.
Yes,
As we say that in the endothelium, it is there,
yes,
in the vessels and other places.
yes.
We know that FSH receptors are there in testicular tissue also.
Yes,
And that is the reason where the testosterone concentrations are high there. In CRPC,
Hmm.
in CRPC, when we say that the castrate levels are maintained and still the autoregulation of tumor occurs, is there any evidence or any effort to analyze that FSH receptors are there as in testis, they are there in the prostate also?
so you are talking of paracrine and epicrine actions of testosterone
Yeah.
production within the tumor cells.
Within
That
the
is a well-known aspect of the CRPC, and one of the mechanisms how CRPC actually is being brought about by the tumor cells that we are aware of. Now, how you are going to tackle this depends on what we have in our armamentarium right now. So, sorry.
So, no, it's fine.
So to tackle paracrine and epicrine production, we have abiraterone. This is the current drug which is available.
Mhm.
And we have ligand binders like enzalutamide therapy and darolutamide therapy, which you have just spoken about yourself a couple of days ago. So these are the three target agents we have. Abiraterone has a more proximal androgen suppression at the enzyme level, but at a ligand binding level, you have enza, darolutamide, and apalutamide. All three, or in fact, all four drugs, therefore, are acting on this microenvironment of testosterone production in the prostate cancer itself.
Right, you are right. And this anti-androgens or chemotherapy or whatever we give, androgen deprivation therapy continues. And
ADT
if
continues.
androgen deprivation therapy continues, then instead of analogs, we can switch to antagonists. That is my proposal, because the CRPC, the now new knowledge is that inflammatory vascular problems are more in the existing comorbidities, whether it is obesity, hypertension, cardiac problems, and therefore we should, according to me, it should be changed to antagonists so that our comorbidities are taken care, FSH is taken care of, and this autoregulation of the tumor
Sure.
is also tackled to some extent.
So
Dr. Samir, anything you want to?
I'll just make one closing comment. There is a very good review by Dr. Klotz, who has done maximum work in the cardiac health of patients on ADT. What he has said, basically today, we probably should pay a little more attention to lifestyle modification. Consider using metformin, consider using statins, because these three in conjunction with the ADT have shown beneficial effects of reducing cardiovascular death. These are easily available, cheap medicines, which we are using in India also very regularly. Most of our patients are diabetic hypertensive. So if you have considered a patient's risk to be high, you should intervene by adding statin and metformin to his therapy of ADT. It helps in mitigating the risks.
You are very on that. I think I agree fully with you. And in the COVID era, when COVID was going on, there were certain trials on hormonal effects on COVID severity and mortality. And in this also it was found that if we give
Statins and
these androgen deprivation therapy, and then the patients are benefited. In fact, if we give estrogen and progesterone, then also patient is benefited.
Yeah.
And therefore, I think this FSH, who knows that this is also playing important role in this era. And positive results have come from all the trials which were done in this period.
Thank you.
So just one question. So in the current scenario, what do you think is the role of LHRH agonist in the?
So the role is very much there. If you have a patient who's fit and is a young patient here, if you have done this assessment, ECG is fine, lipids are fine, you have all the freedom to use an agonist therapy. It is cheaper and it's widely available. So I would not completely negate the requirements for agonist therapy today.
at the same time, we can use it for 3 months, 6 months and all those things, which is convenient to the patient.
And you have now mentioned that oral agents are
Yeah.
also available. So I think we are seeing in the
Yes.
extending the what the question or comment Dr. Samir is
Yes.
forwarding. Future maybe that we are more and more dependent for
Yes.
compliance and other important aspects which are emerging
Yes.
on antagonists in future. But at present, what do you think about 3 monthly preparations of Dagarelix?
So as far as my knowledge goes, they are still in preparation. They have been trying to reduce the size of the injection, and they're trying to have formulations which remain stable over 3 months with sustained delivery levels. As what I have understood from the industry people is they have not yet had an approved drug in this category. So it still
Not
remains
in
monthly.
India, but they have got 3 monthly preparation in one of the country. I think they have exclusive rights, that country.
You're
And,
talking of Germany, but
no,
I'm
it
not
is
aware of.
Germany or Japan. I am not
Okay, okay.
remembering it, but it is definitely available in one of the countries.
Right, sir. Thank you.
So I think with this, we have still time. Dr. Rawal, you want to mention anything in this regard, antagonist and agonist in this?
CA prostate?
CA prostate.
Oral agents have been discussed in HERO trial, so not much to add, only that they are very safe antagonists for patients who have heart disease, and most of the elderly patients do have heart disease, so we prefer to give antagonists, but there is unmet need of having the product which can last for 3 months at least. Patient coming every month is a problem, and suddenly another one problem is the injection site pain.
Yes.
Many patients, they complain. By the time they actually improve in 1 month, then you give one injection more. So that is the problematic. Rather, it doesn't happen with Zoladex, the needle is big, but patient comes after 3 months, they never complain this thing.
Yes.
Thank
So
you.
local reactions are important, and this is the inflammation again locally. And if 3 monthly preparation is there, and we counsel the patient beforehand, that they may be, I always counsel that there may be nodule or some
Yes.
pain, don't worry. So then those patients are comfortable. They will not be apprehensive after this is happening.
Absolutely.
So with this, I think we conclude this session.
Thank you.
And thank you very much, Dr. Aditya Pradhan.
Thank
We
you,
will
sir.
have a short ceremony.
I request one of the
Dr.
chairperson to
Aditya,
please facilitate our
receive the
speaker.
mic. Yes.
Will you- बस कनेक्शन है ना, वही काम करता है तो ये लगा, कहीं लगा, अच्छा उधर लगा।
The idea is that in this now.
ना, मतलब मिलता नहीं है। लॉन्च बड़े पास।
I think now it is the time for the next session. And next session is okay. So next session is on the topic recent updates in the advanced RCC. And this is one medicine which is getting launched here. And this is lenvatinib, and Dr. Sudhir Raval, who is from Rajiv Gandhi Cancer Hospital. He is MD there. He is a very senior and famous uro-oncologist of the country, robotic surgeon, and also the current president of North Zone Urological Society of India, is going to update us on these advances in RCC. Dr. Sudhir Raval, please.
Thank you, Rajiv, and thank you, chairpersons. As you know, the field of RCC changed in 2006 when sunitinib came. Or rather, sorafenib came, then sunitinib came, then pazopanib came, and we had the mTOR inhibitor, which did not make much difference. After that, I think we were having better results what we had before with the interleukin-2 and the interferon. But then another advances occur when the immunotherapy came in this field, and it changed the side effect profile completely, because all NIV were having side effects. They were effective, but this immunotherapy was more effective and less side effects. But then again, it is changing because they are better NIBs have come, better target therapy have come, and their side effect profile may not be as good as immunotherapy is, but their efficacy is very high. And that's what I'm going to talk what is happening in advanced RCC now. So these are the therapeutic biological pathways for targeted therapies in advanced RCC. And we know that most of our patients receive sunitinib and pazopanib as first line. And in second line, treatment strategy focused on continuing VEGF inhibition or using the combination of VEGF or mTOR inhibitor, which were not very effective. Established second line therapy include extinib and everolimus so far. Though there is now immunotherapy also, but if after immunotherapy, then again target therapy is taking over. Newer treatment options, including the combination options, are improving the patient's outcome. These are now NCCN guidelines. They have completely changed. This is 2022 version. And we can see that in favorable risk, there is a extended pemzorolizumab. This is IO, immunotherapy plus target therapy. They are combination. Then cabozantinib and nivolumab, lenvatinib and nivolumab in favorable risk first line therapy. In poor and intermediate risk, the extended PEM, cabozantinib, nivo, EP, and nivo also has been added, which works very well in this. And sometimes it gives very long-lasting results. Though I'm yet to see, I have given it to around 4 or 5 patients. Then lenvatinib and pemzorolizumab, and cabozantinib alone is also a choice of drug in patients who are having poor risk. The other recommended therapy is extinib, everolimus, cabozantinib category 2B, nivo, EP in favorable risk. Pazopanib, sunitinib are there still in the favorable risk. In poor risk, extinib, everolimus can be given. Pazopanib and sunitinib are there. And useful in certain situations are active surveillance. Extinib, high dose IL-2 is still have a role in young patients. And in poor risk, extinib, IL-2 and temsirolimus. So I will talk those few trials I will speak about few trials in my talk. First is CABOSUN trial. This was cabozantinib versus sunitinib in advanced RCC. The randomization was 1:1 and no crossover allowed. And tumor assessment was used. Tumor assessment was done by RECIST 1 by 1 every other cycle, and treatment until disease progression was done. Stratification again was with the IMDC risk group, intermediate, poor, and then bone metastasis, yes and no. Endpoints were PFS and overall survival and overall response rate and safety. You can see this is the results of progression-free survival a marginally better outcome with the cabozantinib, 8.2 versus 5.6 months, and hazard ratio was 6.69. Trend favoring cabozantinib over sunitinib for overall survival was in hazard ratio was 0.80, while in PFS it was 0.69. But this was not associated with statistically significant, and the study was underpowered for definitive overall survival outcome. Then rationale for combination of VEGF and PDL1 and PD1 inhibition is that they have the synergistic effect. 1 + 1 will be more than 2 because they target the different receptors in the cell of which are there in the RCC. And this is again blocking CTL4 and PD1 blockade, which will probably that actually logically, if we say this will give better result, and it does happen when you combine PDL1 and the NIBs. Newer first line combination for patients with advanced RCC. One is IO in combination in RCC. The front line there are few studies. Clear cell study is pembrolizumab versus pembrolizumab plus Lenvima versus Lenvima plus everolimus versus sunitinib alone. Then checkmate 214 is ipilimumab and nivolumab versus sunitinib, overall survival benefit. Keynote 426 is pembrolizumab and axitinib versus sunitinib. Checkmate 9ER trial is nivolumab plus cabozantinib versus sunitinib. And overall survival benefit are there, but this is not yet approved. Avelumab and axitinib versus sunitinib, PFS benefit, it is FDA approved. iMotion 151 trial, atezolizumab plus bevacizumab versus sunitinib, PFS benefit, but not approved again. So I will talk about clear study of phase 3 trial where Lenvima plus pembrolizumab or everolimus versus sunitinib monotherapy as a frontline treatment was given. So these are the 3 arms. The metastatic RCC who are eligible, they were divided into randomized into 1:1. One arm received Lenvima plus pembrolizumab. Then another arm received Lenvima plus everolimus, and third arm was sunitinib alone. These were compared, and they were compared with PFS. Secondary point was overall survival, response rate, safety, health-related quality of life, and then key exploratory analysis was duration of response and biomarkers. Clear study. Statistical consideration were enrollment of 1050 patient was planned and 1069 patient were randomized. Final PFS and interim overall survival analysis were based on 28 August 2020 data cutoff date. Median follow-up was 27 months at 388 PFS events for 90% power with two-sided, so that you can see, you can evolve them statistically. The observed number of the final PFS events, 365 for Lenvima and PEM versus sunitinib, and 396 events for Lenvima and everolimus versus sunitinib. PFS and overall survival difference between Lenvima and PEM versus sunitinib and Lenvima and AV versus sunitinib were evaluated for stratifying the log rank test. So this was a very powerful study. These are baseline characteristics, and they are almost same in all 3 arms. And if we go for PFS in Lenvima and pembrolizumab, you can see the hazard ratio is great, 0.39. This is one of the best hazard ratio, and the survival was 23.9 months versus 9.2 months. We have not seen these data so far in any other drug. If you evaluate Lenvima and everolimus, which are oral drug, both of them, then the hazard ratio was 0.65. It was not as good as Lenvima or PEM, but is still better than sunitinib. And then the PFS was 14.7 months. In all the subgroups, this Lenvima and PEM worked in all the subgroups of sex or geographic section or region or PDL1 expression, IMDC risk group or prior nephrectomy or any place. Same, I think I have time. I had 20 minutes. So this is, I have 20 minutes, isn't it? Yeah. Okay. So on PFS, if you see Lenvima plus everolimus, again, it was good in all the subgroups. Can you stop this, please? And overall survival in patients who have received the Lenvima and pembrolizumab was also better, and it was statistically significant. Hazard ratio was 0.66, and it was 33 months in Lenvima and pembrolizumab. While in Lenvima and everolimus, this was hazard ratio was 0.88, which was not that great as was with the pembrolizumab and everolimus, but still it showed some better, but it has not reached, so maybe not evaluated. When it gets evaluated, we will get the data. The overall survival in Lenvima plus pembrolizumab in key subgroups was again better, almost everything, every group except in the favorable histology. About the intermediate and poor risk, it was even good. Confirmed objective response rate was seen like in Len and Pemi, it was 16.1 was complete response rate, which have not been seen so far in any drug combination. Partial response was 54.9. Almost 70% of the patient will respond to the Lenvima and PEM combination, which probably can be used in the NA neoadjuvant therapy also. While Lenvima and everolimus also showed complete response in 9.8 and favorable response in the partial response in 43.7, which is also have a good data if patient cannot afford the pembrolizumab. Len and Evi, probably they are cheaper. Duration of response with Len and Pemi was great. It was 20.58 months, better than sunitinib, which was 14.6 months. And if you see Len and Evi, then it was 16.6 months, which was not great as sunitinib was, but still it did show the marginally better response, better duration of response. Treatment, safety, and discontinuation were seen almost same as in with the sunitinib, 92%, 97%. This was patients with any adverse event, 96%, grade 3 and grade more than grade 3 events were a bit more with Lenvima and Evi. It is expected both are different class of drugs and they both have side effects. While sunitinib was less, and Len and Pemi also had a bit higher grade 3 events. Mainly the Len and Pem has the side effects of the hypertension. You can see here the hypertension as the adverse event is more with Len and EV combination, PEM and EV combination. One of my patients who was on this combination, we had to reduce the dose of Lenvima, but then probably we have to stop it because his hypertension was not getting controlled. But probably that's the best biomarker also that patient will respond, and that patient is doing very well as far as disease is concerned. So in conclusion, we can say that Lenvima plus pembrolizumab demonstrate significant improvement in PFS, OS, and overall response versus sunitinib. Lenvima and everolimus demonstrated significant improvement in PFS overall response, but not overall survival versus sunitinib. The safety profile of Lenvima plus pembrolizumab and Lenvima plus everolimus were consistent with each drug's known profile and were manageable as needed dose modification. These results support Lenvima plus pembrolizumab as potential first-line treatment for the patients with advanced RCC, with probably the best result in this segment. Then the CheckMate 214, where Nivu and EP has been compared with sunitinib. We know about this trial. This drug is there in the market. This is randomized 1:1 in arm A. Patient received 3 mg per kg of nivolumab plus 1 mg per kg of ipilimumab Q3 weeks, every 3 weeks for 4 doses, and then followed by nivolumab at 3 mg per kg every 2 weeks. In arm B, sunitinib was given for 50 mg orally once daily for 4 weeks and a 6-week cycle. Treatment until the progression or the unacceptable toxicity. And here you can see the hazard ratio is 0.86, p-value is significant. Nivo and EP showed the better overall survival in these patients, and the long-term sustaining survival or the disease control was seen in Nivo EP arm, which actually sometimes compares with the interleukin 2. And PFS was better in Nivo and EP arm. Then overall response rate and overall response by IMDC risk category, it was better seen in the patient who had intermediate and poor risk in comparison to the favorable risk. So this is the drug of choice for the patient who have intermediate and poor risk, where this gives the very good response and very good survival advantage in PFS and overall survival also. Next is Keynote 426, where pembrolizumab plus extrinib in the treatment-naive advanced RCC. The key eligible criteria were same as for any trial in the advanced RCC, and the randomization was 1:1. And here pembrolizumab 200 milligram IV infusion every 3 weeks for 35 cycle plus extrinib 5 mg orally daily twice a day, versus the sunitinib was evaluated, and they showed overall survival in intent to treat population was again better than the sunitinib. It has not reached rather, and sunitinib it has reached. And PFS again was better in the patient who received pembrolizumab and extrinib, which was 15.4 months versus sunitinib 11 months. Keynote 426, overall survival, PFS and overall response rate with IMDC favorable risk also was seen. Like here you can see PEM and DEXY is shown complete response in 11%, while sunitinib in 6% only. The overall survival was this, and the PFS was this. So there was not much difference, but it has shown better overall survival and PFS in patient with favorable and intermediate and poor risk. Yes, it has done better than favorable is favorable. It is same as IO like Nivo EP. It is better, actually has the effects in patients who have intermediate and poor risk. So Nivo, next combination is Nivo plus cabozantinib versus sunitinib. And in this is the CheckMate 9ER trial. It was presented at ESMO 20. Again, Nivo and cabozantinib combination was compared with the sunitinib alone. And they showed that PFS was great. This is 16.6 months versus 8.3 months. So we have many drugs in the first line of RCC now, and it was effective in all the subgroups. Same was overall survival with Nivo and cabozantinib. It has not reached, while in sunitinib it has reached around 22 months. But as you can see that this drug is again effective has better overall survival in all the subgroups when used as first line. Then the atezolizumab plus bevacizumab versus sunitinib. Here they have compared the atezolizumab to 1200 milligram, which is again in immunotherapy, versus plus bevacizumab 15 milligram per kg versus sunitinib 50 mg. And this has shown the median FSS is better in atezolizumab and bevacizumab arm, and median progression-free survival in intent to treat population is almost same. It's not a great difference, but it does show that it has some better effect than the sunitinib alone. Then median overall survival in the patients who in the same overall survival is also though not much difference, but it has shown some better effect, not a great difference in intent to treat population and in the patient who have PD-L1 positive. So these are side as the PD-L1 positive where the results are better. These are the graphs with the patient who actually are all the patient who are being treated. Javelin Renal 101, where avelumab and extrinib is compared with the sunitinib. And this is the drug which is recently launched in India. It is available in the market. You can use, and they have shown that intent to treat population also showed the better overall median PFS, and overall survival was not much of difference, but median PFS was definitely statistically significant, 13.8 versus 8.4 months. Avelumab and extrinib shows PFS and overall survival in PD-L1 positive patients much better than the intent to treat population, And here you can see that PFS and overall survival were both better in the patients who received avelumab and extrinib. These are all scoreboards of all trial. I'm not going to go in detail because I have told you, but the best, I think, results we have seen is with the lenvatinib and Lenvima plus pembrolizumab. So first line treatment trial summary, I can say the risk stratification is an important parameter to choose the right treatment option. Good risk patients and those with favorable intermediate risk patient can have survival for many, many years now. Availability of new IO combinations are creating paradigm shift in the management of metastatic RCC. Systemic for the second line beyond advanced RCC, we have some data. As we know that management of advanced RCC remains a clinical challenge now, and 5-year survival rates drops to 67% for patient with regional metastasis and 12% of the patient with distant and metastatic disease. But we do have the disease drugs in first line, second line therapy, we have third line therapy, and the fourth line therapy also. Sorry. Selecting second line therapy, you have these options, either extrinib, nivolumab, cabozantinib, or Lenvima and everolimus. And if you see the here, overall response rates are maximum in Lenvima and everolimus. This combination, this drug is effective in second line also. Progression of disease was also less in the Lenvima arm when you see that they all were treated with prior TKI and the data almost same. Here rather 700% of the patients were refractory. So Lenvima and Evi combination showed better overall response rate and decrease in the incidence of progression of the disease. And PFS was 12.8 months, which is the best. And then overall survival was again 25.5 months. So logic tree for selecting second line agent after sunitinib or pazopanib, it has to improve the clinical outcome versus existing standard. If you are finding the new drug or you're deciding any drug. So this is actually extrinib and everolimus alone, they do not do this criteria. Lenvima, cabozantinib and nivolumab, they do that, they improve the clinical outcome and versus the existing standard. Also, one has to see, does it improve the response rate, overall survival and PFS? Nivolumab does not increase the response rate, overall survival or PFS, but it does have the less side effect. So once the patient is shifted from sunitinib to nivolumab, the patient feels better. He says that I'm improved. While Lenvima and everolimus or cabozantinib, they do increase the response rate, overall survival and PFS in second line. What about cabozantinib versus everolimus in advanced RCC? This has been compared 1:1 trial. Inclusion criteria are same. And these are the results. Overall survival is not much difference. And progression-free survival definitely is better in patients who receive the cabozantinib. Lenvima plus everolimus in second-line RCC, a detailed review. This is the mechanism of action. A potent inhibitor against the mammalian mTOR inhibitor is everolimus. It induces the cancer cell death and inhibition of angiogenesis. While we know Lenvima works on a different receptor. These are the synergy in the animal model which has been seen when you use Lenvima and everolimus combination. And this is the phase 2 trial which was reported by Robert Modger with lenvatinib and everolimus and the combination in patients with metastatic RCC in Lancet Oncology. This is the HOPE trial which was done using Lenvima plus everolimus or Lenvima alone versus everolimus alone. And here the characteristics of baseline characteristics were same in all the arms, and maximum patients had poor MSKCC risk in this trial. And these are the results. Medium progression-free survival with Lenvima plus Ebi versus everolimus alone was better in combination in Lenvima and everolimus arm, and hazard ratio was 0.40. It was PFS was 14.6 months versus 5.5 months. And when you go for overall survival, also it was better in Lenvima and everolimus arm. And these are tumor response, which was seen better in Lenvima and everolimus arm versus the everolimus alone, and duration of response was 13 months versus 8.5 months. In phase 2, study 205, Lenvima in combination with everolimus and RCC, median overall survival was 25.5 months versus everolimus alone, and it was 15.4 months in everolimus alone. So treatment emergent adverse events were not as great as if you see, then one has to be very careful. But then one has to explain the patient and take care of these things, because patient can have diarrhea in 84% of the patients, fatigue, asthenia, decreased appetite, vomiting, all NIBs, all target therapy, they do have side effects. And also the everolimus has the particular side effect of pneumonitis. These are NCCN guideline for the patients who are actually who are category 1 regime as per NCCN. And this is the subsequent therapy. If you go, the cabozantinib category 1, lenvatinib plus everolimus is a category 1 again, and nivolumab. These are 3 drugs of choice in second line therapy. Other recommendations are there. Any drug can be used if it has not received. So in later lines, one can say in summary that evidence suggests that excellent activity of TKI based regime in second line. It's not that you have given the TKI, the next TKI will not work, but because VEGF receptor is not a small receptor, it's a long receptor, so the drugs still work there. Lenvima based combination is promising and has potential to become new standard of care in second line after TKI failure. Subsequent therapy, sequencing therapy remains the standard in face of current first line IO regimes. However, standard treatment is not defined after these treatments. Cabozantinib and nivolumab may be beneficial in selected few patients. Thank you.
Thank you, Dr. Rawal. If there is any quick comment, it is welcome. We are running short of time. Is there any? Yes.
All these drugs after the,
Yes, sir.
yeah, please.
Sir, which histology were included in the all study, clear cell or all kind of histology?
No. Actually, all immunotherapy, they work against any histology.
Right.
In general, target therapy, they do not work except against the clear cell.
Clear cell.
They don't work against other histology. We did not have any option, so we kept on giving sunitinib as the drug which was given to non-clear histology also. But now this all immunotherapy, they work against all histology. So if you have another, like if you have mixed histology like clear cell, sarcomatoid or something,
Papillary.
so you must add immunotherapy in your armamentarium. If you add another target therapy, that gives the best results as on today, which is shown.
And what is your comment upon the adverse events, like in the tune of 70%, that too more than grade 3? So what is your
Adverse
first-
events are higher. I agree with you. They are not a benign drugs. They are not a just a innocent drug. They do cause adverse event, and you have to explain the patient. You have to take care of them. You have a pre-hand. If they are causing too much adverse event, you can tell them you can reduce the dose. And if a patient is not improving, you may have to change.
And further, they have not included the placebo arm, because to explain the patient, if you are taking the treatment, then what would be your fate, and if you not take the treatment with
Placebo, actually, ethically you can't do. You said placebo, isn't it?
yeah.
Because there is standard of care is sunitinib.
Suppose some patient do not not able to receive sunitinib because of adverse event or some other reason, then he will be off treatment.
No, you can change sunitinib. You can go to pazopanib, you can go to sorafenib. You have to nowadays, if we are not giving any drug to, unless the patient has got minimal disease, those are active surveillance is different. But if you are putting patient in trial, you have to use sunitinib because that's the standard
trial,
of care.
yes.
In the trial.
Yes.
But in your practice, it's always different.
Okay. Thank you, sir.
Thank you, Dr. Rawal. It was a wonderful presentation.
Thank you, sir.
Thanks a lot.
Photo.
Now I request chairperson to please felicitate our speaker, Dr. Rahul. Thank you all the chairpersons and speakers. Now I would like to invite chairpersons for moderated podium session 7, Dr. B.S. Wazir, Dr. Amitabh Singh, Dr. M.S. Jha, and Dr. Amrendra Pathak. And please start the session.
Yes, sir. Good morning. Welcome to this podium session 7. We have 6 papers in this session. The first paper is by common disease nowadays, that is COVID-19. So our first speaker is Mr. Dr. Naveed Mehta, Niro Mehta from SMS Medical College, Jaipur. Renal effects of COVID.
Eight minutes. 8 minutes. 2-minute discussion.
2 minutes discussion.
Good morning to all. My topic presentation is renal effect of COVID-19. It all started in December 2019 when another coronavirus hit the world with its major epidemic. Later on in February, WHO named it as COVID-19 and subsequently it was declared as a pandemic. It had a very wide range of clinical presentation, mainly related to respiratory system. Although several literatures have illustrated the mechanism for dissemination to the multiple organs, data regarding its pathophysiology and so the management protocol were quite limited. We have here dealt with mainly kidney involvement in COVID-19 patients. Novel coronavirus uses ACE2 receptor as a cell entry receptor, which is in addition to respiratory system also present in GI and GU system. So it's quite possible that it may directly insult the kidney And also the literatures have showed the kidney involvement in patients of COVID were far more than the other pneumonias. So this result highlights the importance of identifying the burden of renal involvement in COVID patients. Our aim is to identify the incident rate of renal involvement in COVID patients that could further help urologists and physicians to identify the pathophysiology and importance in management protocol of the patients. We have analyzed patients admitted in RUHS Hospital Jaipur, which was designated as COVID dedicated hospital. Ethics approval was taken from the Institutional Ethics Committee. All patients were diagnosed with the RT-PCR test, which was advised by the Ministry of Health and Family Welfare India, according to the protocol. And we have collected baseline demographic data and all the lab investigation patients during the admission. We have all the patients were treated according to the guideline provided by the Ministry of Health and Family Welfare, as there was no protocols for the treatment of the disease. Also, the patients were stratified according to the guideline provided by the Ministry of Health and Family Welfare in asymptomatic, mild, moderate, severe, and critical patients who required an ICU admission. Acute kidney injury was defined by the criteria given by Kidney Disease Improvement Global Outcome Criteria. Inclusion criteria, we included patients having COVID positive between age 15 to 60 years, having no pre-existing renal disease, or not having any pre-existing comorbidities. All other patients were excluded. Our study design was prospective observational study. We have measured 450 patients after excluding ineligible patients. Out of their 135 were the female patient. Median age was 42 years. And out of 45 patients were required ICU admissions. The pooled incidence of acute kidney injury in patients of moderate to severe severity were 10% incident rate, with the mean duration of renal involvement was 5 days and range from 0 to 20 days. In ICU patients, on other hand, the acute kidney injury incident rate was 30% and mean duration of presentation was 2.5 days. Other proteinuria and hematuria were seen in many number of patients on the day of admission also. And the incident rate was 5 and 1 in moderate to severe patients, and it was 27% hematuria in ICU patient. Although the lung was commonly accepted as the primary target organ, COVID-19 has exhibited kidney dysfunction in quite a number of the patients. Initial reports from the Wuhan, China, published by Zhang Late et al. Has shown quite a low number of incident rate of 3 to 9% of kidney involvement in COVID patients. So, and contradictory to that, subsequent studies from the Western world, American countries or US and Europe countries, Subham Agarwal et al. And Jamie S. Hirsch et al. Have showed very high involvement of renal involvement in COVID patients, ranging from 20 to 46%. And in certain study, it was also shown AKI incident rate was 68%. This is the difference between Chinese and Western world studies. Chinese have reported very low incident rate of and US and Europe studies have showed very high involvement of renal and kidney failure in COVID patients. So there was a quite dilemma regarding the actual value of renal involvement in COVID patients. Also, it was observed and found that COVID has behaved differently in different part of the world. Like there was more severity in Western world, and it was mild in Indian and Indian subcontinents. So here we have specifically analyzed the kidney function of COVID patients in Indian scenario, which was very less, or we couldn't find any article regarding. And the occurrence of the kidney involvement in COVID can be explained by the one theory is kidney lung crosstalk theory. Second was common anti-receptor of both. Another mechanism could be coagulation or D-dimer, and inflammatory reaction could affect the kidney. And our result is largely comparable to the other studies, but there were some limitations also. Like our center was primarily a referral center, so most of the patients treated was moderate to severe severity, and the mild asymptomatic patients, according to the government guideline, were treated at either home isolation or peripheral centers. Secondly, various drugs and intervention used in COVID patients during treatment could also have contributing factor to kidney involvement that could not be differentiated. Another, the population we studied from the single center and single region of the country, and no intervention visit was observed in the study. although we have highlighted the burden of the renal involvement, the incident rate of renal involvement in COVID patient and non-comorbid patients in Indian scenario was not so alarming. Although we suggest a high degree of caution in monitoring the kidney function, and the clinician should consider any potential intervention in early stage of the disease if any suspected renal involvement is found, because proteinuria and hematuria was found even on the day one of admission. That could be an early presentation of renal involvement in COVID patients also. So early intervention could prevent the severe disease later on. Thank you, sir. These are my references.
You evaluated so many patients
Yes, sir.
for COVID. So have you gone through any study which have detected COVID virus in urine?
Sir, very few studies have also detected. Like 4 or 5 studies I have found, they have found in urine also, sir.
Okay. So
But
what-
that was again, there was a lot of confusion regarding the testing of urine virus and the.
So what is the take-home message from this study?
Sir, the differentiation in the presentation of Indian subcontinent and Western could be one of the reason could be racial or genetic mechanism. And one thing that although we can, the initial presentation of hematuria and proteinuria like were seen on day one only. We can keep a high index of suspicion on the initial stage, and that could we can prevent further severe disease, because kidney involvement, as we know, this researchers have said that renal involvement has high mortality in COVID patients. So we can prevent the severity later on by early suspicion.
How can you differentiate between these renal effects are with COVID only?
No, that's
or
what the
with
limitations are.
drugs?
Yes, that's what I have said in limitation. The renal effect could be due to drug. Many patients were in ICU. Other intervention could also lead to, but that is the limitation, that we could not differentiate between them. But it has been said that literatures have published and proved that the renal involvement in other pneumonias were not so much. So this we can differentiate that this could be due to the COVID. So what additional effect has been seen due to the COVID may be there, because other pneumonias were also there, but the renal involvement was not so much in other pneumonias. Thanks.
Okay, thank you.
So next study is retrospective cohort study for complex enterourethral stricture, perineal urethrostomy as single stage approach. Mukesh Chandra Arya. He is from Bikaner.
Good morning, everyone. Myself, Dr. Rakesh Singh. I am presenting on perineal urethrostomy, a single stage viable option for complex anterior urethral strictures. The surgical options for anterior urethral strictures, they are extremely diverse, and they include endoscopic procedures to various urethroplasty techniques. The success rate of urethroplasty procedure is variable and is quoted up to 80% or higher. Complex urethral strictures, they are not amenable to one-stage urethral reconstruction. Therefore, in such cases, perineal urethrostomy remains a single-stage surgery with high success rate. The aim is the evaluation of the functional outcome of permanent perineal urethrostomy with or without Johnson stage urethroplasty. It is a retrospective study in which 124 patients were included. And we evaluated the etiology of strictures and previous therapies and the need for further subsequent interventions. This is a table showing the number of patients corresponding age group in our study. 88% of the patients, they were from 40 to 80 age group. And in our study, prior catheterization was the main etiology in around 85% cases. And we excluded the patient with posterior urethral stricture or having bladder neck contracture. In all our patients, we did the suprapubic catheterization and routine hematologic and biochemical investigations and urine culture and retrograde urethrogram and micurating cystourethrogram. In our study, total 124 patients, they were included. Out of 124, 71, they underwent Johnson stage 1. And out of 71, 27, they are waiting for stage 2. And in which 32 they have denied for second stage procedure on follow-up. Patient, the surgery they was done under spinal anesthesia, patient taken in lithotomy position, and we done antegrade and retrograde urethroscopy using 6 to 7.5 French ureteroscope. And guide wire was placed if feasible. This is a table showing number of patients who underwent PU only. Out of 124, 53 patients they underwent PU only, and success rate was 95%. And out of 124 who underwent PU with Johnson stage 1, 71 patients, success rate was 87, and who underwent Johnson stage 2, 12 patients, success rate was 75%. This is a diagram showing the marking of the incision for perennial lithostomy flap, and the inverted U-shaped flap, perennial scrotal flap was made, and then further bulbospongious muscle was separated, then antegrade bougie was placed, and bulbar urethra was opened, and then stage stitch was taken. Further, the scrotal skin, they were sutured to urethral mucosa and with interrupted bical 30. And if in case of very bad urethral plate, the buccal mucosa graft, it was put, and the rest of the wound was closed in 2 layers, and catheter was kept for 7 days. Patient was followed at 6 weeks, and then 3 months for complaints, and further, and uroflowmetry was done. After 3 to 6 months of first stage patients, stage 2 was done if stoma was adequate. In case of stomal stenosis, buccal mucosa graft was extended in posterior urethra at 12 o'clock. The urethral plate to be tubularized was marked with 2 parallel incisions 25 mm apart, making it U-shaped at the site of perennial ureterostomy. This is the following the diagram showing, first diagram showing the post-operative appearance of Johnson stage 1 PU. The second diagram showing Johnson stage 1 after 3 months. In the further diagram, third showing tubularization of Johnson stage 1 PU, and fourth diagram showing post-operative appearance of Johnson stage 2. The neo-urethral reconstruction was started proximally of 14 French silicon Foley's catheter. Tunica vaginalis flap was mobilized and suture line, they were covered like a blanket wrap to minimize the risk of fistula formation. And third layer consists of ventral dartos, and finally skin was closed. In our study, mean age of the patients was 4 years, and out of majority of the patients, they were 38%, they were in 60 to 80 age group, and majority of the patient, they had acute urinary retention, and in our study, the indication prior catheterization was main indication for the PU, and the rest were failed urethroplasty, BXO, post hypospadias. Following constitute complex urethral structure, patient having pan anterior urethral structure with lumen less than 5 French, BXO, multiple failed urethroplasties, prior hypospadias repair, multiple obliterations, or periurethral abscess or urethrocutaneous fistula. Consequently, PU remains a successful and viable single-stage option in those with advancing age and little physical activity. PU virtually suits them as they are not the candidate for the extensive surgery. They do not mind voiding in sitting position. In young patient, no desire of permanent PU. Two-stage urethral reconstruction can be combined with it. Conclusion: even in expert hands, complex anterior urethral stricture, they have very low success rate in single-stage procedure. Therefore, PU is a viable option in such cases. Following are the reference. Thank you.
In your study, in which you have done Johansson 1 and perennial urethrostomy, the success rate is, I think, 81%,
70,
70%.
75%.
So what you think that the cause of failure in 25%, because perennial urethrostomy is a sure and certain procedure, and you shows 25% failure rate.
So 75% success rate in those patients who underwent Johnson stage 2 procedure as well. In these patients like BXO, failed urethroplasties, multiple previous urethroplasties, post hypospadias, these patients were included. That is the main cause of having success rate 75%.
So what is the incidence of meatal stenosis in your case?
Sir, meatal stenosis is now one out of 124 patients, 12 patients they having around 10% were having meatal stenosis.
So they need dilatation
Yes.
in the interval period. So what
Yes.
is the most important stage to prevent meatal stenosis? Technique. Which precaution you will take to prevent meatal stenosis in perennial urethrostomy?
Sir, first the urethral mucosa, the urethral lumen should be patent, should be wide, and the flap should be sutured meticulously with urethral mucosa.
Yes.
And further, we can do CIC subsequently in post-op period.
Did you think that etiology was important in success rate of your,
Yes, sir.
which was the commonest one?
Sir, prior catheterization was the most common cause of all the strictures, but success rate was very less in BXO, like patient having BXO. That is why it is important. Yes, sir. Yes.
Yes.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Role of re-stage TURBT in non-muscle invasive bladder cancer. Koti Sridhar Reddy
Yes.
from Varanasi.
Yes.
Go ahead.
Good morning, one and all. I, Dr. K. Sridhar Reddy from IMS BHU, present my study of role of restage TURBT in non-muscle invasive bladder cancer among variant histology. The incidence of variant histology among National Cancer Database from 1998 to 2014 is 6.4%. But as per the recent studies, the incidence is as high up to 33% among the radical cystectomy specimen. This is due to the fact that in 2016, WHO published the updated classification of urinary bladder cancer, emphasizing on the variant histology and its importance in reporting. Apart from that, the increased availability of molecular markers and the increased standard of the pathologist could be the other attributable causes. Though EAU and AAU stratified their variant histology under very high risk group, suggesting early cystectomy, certain variants like adenomatous and squamous differentiation and nested variants, BCG installation is still followed. And even in certain variants, surveillance is followed among the TA staging. Pondering on the fact that there's a discordance between the staging of TURBT and final radical cystectomy specimen, restaged TURBT helps us in getting to the better staging before the definitive therapy and helps in better management of the patient. Hence, our study aims at evaluating the instance of various subclassifications of variant histology and instance of residual tumor, change in staging, and its correlation with various factors during restaged TURBT among variant histology non-muscle invasive bladder cancer. It's a retrospective study conducted in the Department of IMS BHU from the duration between Jan 2015 to June 2021. All the patients who underwent TURBT for bladder cancer and histopathology came out to be non-muscle invasive bladder cancer with variant histology, and those who underwent restaged TURBT within 2 to 6 weeks were included in the study. The patient who was lost to follow-up after initial TURBT and the patient who opted for upfront cystectomy were excluded from the study. The total of 520 TURBTs were done, and of which 76 were non-muscle invasive bladder cancer with variant histology. And these are the results at the initial primary TURBT. The median age was 64.6 years, and of which 59 were male and 17 were female. And 59% of the total variant histology is constituted by squamous differentiation and glandular differentiation, and 61.8% were T1 and 38.1 were TA. 25% of the patients had multifocality in the initial primary TURBT, and 25% the muzzle was absent in the initial TURBT specimen. At restaged TURBT, there were 26.3% had a residual tumor at restaged TURBT, and tumor upstaging was seen in 38.1%, with more pronounced in the glandular differentiation and nested variant. And upstaging to muzzle invasion was seen in 31.5%, that is 24 patients. And these are the multivariate analysis comparing the various variables of primary TURBT and the restaged TURBT among various subclassifications of variant histology. And to summarize them, there is a positive correlation between the multifocality with residual tumor, and there's a positive correlation between the multifocality and absence of muzzle in the initial TURBT specimen with tumor upstaging and upstaging to muzzle invasion. The total number of patients who underwent radical cystectomy are 35. Of them, 24 of them are muzzle invasive bladder cancers who progressed to muzzle invasion, and rest of them were the squamous small cell and plasmacytoid variants, where irrespective of the T staging, we have subjected them to radical cystectomy. And the patients who were started on BCG installation were 19, and the patient on observation are 22. Though such study we couldn't find in literature to the best of our knowledge, these studies have been mentioned. These are the various studies where restaged TURBT was done in pure urothelial carcinoma, where the residual tumor has been seen between 24.2% to as high as 64.2%, and upstaging, tumor upstaging was seen from 16.1 to 23.1%, and upstaging to muzzle invasion was seen from 6.8 to as high as 23.3. Then this is less compared to our study, where the tumor upstaging has been seen in as much as 38%, and in upstaging to muzzle invasion has been seen up to 31%. This could be explained by the fact that by inherently the variant histology have a high aggressive nature. The limitations of a study are that it's a retrospective observation study, and the population is less to compare the significant clinical significance among various subclassifications of variant histology. And tumor downstaging, which is a well-known phenomena in variant histology, could not be included in the study because radical cystectomy specimens have not been included in the study. Moreover, the long-term follow-up of the patients have not been done, though it's not the main aim of our study. To conclude, tumor upstaging and upstaging muzzle invasive bladder cancer in variant histology is high, and a restaged TURBT is to be performed in all cases of non-muscle invasive bladder cancer in variant histology, not otherwise considered for earlier cystectomy, irrespective of the T staging, TA or T1. Thank you.
What is the early survival rate in a patient who underwent radical cystectomy?
So, in my study, we haven't compared any, we haven't done any follow, we haven't done a study that is not related to the early survival and late survival of the patients. So it was just comparing the early, initial TURBT, and we compared with the restage TURBT. That's the one of a limitation, because we couldn't do the follow, but that was not a main aim or objective of the studies. Yes, sir. None, sir. None. None. All of them were given a BCG after restage TURBT, who were non-muscle invasive bladder cancer, and we didn't give any BCG to the patients who already had squamous cell plasmacytoid variant, where it's already literature shows that there's no role of BCG in them. Yes, sir.
You said the duration was 2 to 6 weeks.
Yes, sir.
Restaging.
Yes, sir.
So what was the principle of waiting for up to 6 weeks for doing a restaging?
That's what is followed in pure urothelial cell carcinoma, that where restaging, restage TURBT is done after within the gap of 2 to 6 weeks after the initial TURBT.
Usually 2 to 3 weeks, 6 weeks means if you are planning a restaging, you should do it within up to 3 weeks so that you plan the further treatment accordingly.
Sir.
Suppose restaging does not upstage the disease, then you have to plan for the BCG.
Yes, sir. Yes.
So on multivariate analysis, did you find that this variant histopathology increases the stage upgradation or like?
Yes, sir. The thing is that when we compared all the variant histology, including all the variants, yes, we found that it included the variant histologies have been associated with greater incidence of tumor upstaging. But when we have taken all the subvariants of the variant histology, in that cases the numbers are not statistically significant. They were like 5 or 6 cases, so we couldn't make a statistical analysis out of it. That's the other limitation by I said there is the studies population is limited.
Okay.
What is
I am saying different point actually. So there are 2 ways of doing multivariate analysis. So one method is just you make a cohort of all those patients who had a variant histopathology. It doesn't matter whether he had a glandular differentiation or micropapillary or squamous differentiation. So that is one way. Another way is just you separate this cohort into various parts. Those patients who had micropapillary, those patients who have a glandular differentiation, those patients who had a squamous differentiation. So I am talking about in toto. Those patients who had a differentiation from the normal variant histopathology, that is urothelial carcinoma, does they have any bearing on the upstaging or not?
Yes, sir, they do.
They do.
They do. Yes, sir. Though we didn't directly compare them in our study, where we have in our study we have taken only the variant histology, and when we came out with how many of them had a upstaging in the tumor, and we compared it with the other studies where there was done in pure urothelial carcinoma, the table which I showed.
Okay, because logically, if you see, if you do a radical cystectomy in all these patients, only micropapillary and nested variant probably is the only one type which you find that the radiologically the disease was stage 1, but after doing radical cystectomy you will get a stage 3 disease, because there would be some microscopic spread into the lymph node, or there would be some microscopic spread into the muscle or perivesical fat. So it is not a known phenomena with the squamous or glandular differentiation. It is known phenomena with the micropapillary variant especially. So that's why it has been suggested that if there is any micropapillary variant, then always suggest these patients for the early cystectomy, immediate cystectomy. So that's why I wanted to know in toto whether this as a cohort, this variant histopathology has any significance in the upstaging on multivariate analysis or not.
Yes, sir.
Because that was very important.
Yes, sir. Yes, it does have. It does have. And second thing is that our study, we noticed that apart from nested variant, even glandular differentiation as a sub cohort had an increased association with muscle invasive bladder cancer after restage TURBT, apart from variant histology.
Okay. So another question, these TURBT must have been done by different surgeons.
Yes.
Some must have been done by the residents, some must have been done by the just joining consultant, like assistant consultant.
Yes, sir.
So that is the actually has a basically impact on the quality outcome. Because if you see, in our country, if you ask any premier institute, they don't go for the returbat after doing turbat if it has been done by the consultant.
So,
Okay, so is it like standard practice at BHU, like every patient who is having high grade disease or T1 disease where muscle is not present, or whether there is a not muscle invasion present, you always submit these patients for the returbate?
Yes, sir, we do. We do. For
You
all
always do.
patients, we always do. We always do. And still, sir, in our study, the muscle invasion of the muscle in the initial TRBT specimen was taken in almost 75% of the patient, which is comparable.
How long you have followed these patients after TURBT?
Sir, follow-up has not been done, sir, first thing. And second thing is that the study ended in June 2021. So I can't comment on.
In
the
review
follow-up.
literature,
Sir.
have you found the role of radiotherapy and salvage chemotherapy or in this?
In
highly-
certain variants like small cell carcinoma and micropapillary small cell carcinoma specifically, the radiation, I mean, chemotherapy is advised.
So in my personal experience, whatever you do, the prognosis is not very good in this group of patients, whether you do cystectomy or whatever.
So
The take home message is that if there is any variant histopathology, you always submit this patient, you should always submit this patient for the returbate.
if the patient is being opting, if the patient is not eligible for upfront upfront cystectomy, even we exclude the patient who opted for upfront cystectomy of variant histology patients.
But you don't do upfront cystectomy for all variant histopathology.
No.
So it means you always need to submit this patient for the returbate just to see whether there is any like upstaging in the disease or upgrading in the
If
disease.
patient don't opt for upfront cystectomy, suppose the patient is TA and the patient has variant histology, we subject him to restage TRPT. And if stage patient is T1 and variant histology, the option is given to the patient whether he wants to go for we say the pros and cons regarding both to the patient.
So that's why I am saying. So early cystectomy is not advised for every type of variant histopathology.
No, sir.
It is only justified for the like nested micropapillary and sarcomatoid sort of thing.
Yes.
So if you find this squamous differentiation or glandular differentiation, then you are advising these patients for returbate whether there is any upgrading from T1 to T2.
Yes, sir.
Because
Yes,
if after TURBT it turns out to be a T2, then he would be a candidate for the radical cystectomy.
Yes, sir.
Otherwise, he won't be a candidate for the early cystectomy.
Yes, sir.
So you mean to say if there is any sort of variant histopathology, he should undergo for this returbate.
Yes, sir.
Thank you.
Thank you, sir.
Thank you. The next paper is Robert assisted radical prostatectomy improving urinary continence by Sumit Chaturvedi, Max Super Specialty Hospital, Saket, Delhi.
Good morning, everyone. Thank you, organizers and chairpersons, for this opportunity. Not a lot of data, but point of technique that we have been doing in our cases to improve continence. So robot-assisted radical prostatectomy is an established procedure for localized carcinoma prostate, and urinary incontinence is the major concern in these patients. The literature says that if we define incontinence as the use of at least one pad a day, at 1 year after RARP, the incidence varies from 4 to 31%. So it's quite high. And post-prostatectomy incontinence causes substantial decrease in the quality of life of these patients. So the etiology of post-prostatectomy incontinence is multifactorial, but the surgical factors play a major role. So what we have done is we have categorized these factors into pre-operative, intra, and post-operative parameters that we take, and I'll discuss them one by one. So all patients who have been diagnosed with localized CA prostate after the biopsy and planned for RARP are advised pelvic floor muscle training for 4 weeks before undergoing the procedure. Smoking and uncontrolled diabetes has been labeled in various review articles to be a factor in incontinence post-operatively. So all are asked for smoking cessation, and good glycemic control is ensured. And the most important part is to counsel regarding the realistic expectations after the surgery regarding continence. A few intraoperative modifications that we have done is that those patients who don't have any disease at the base, we try and preserve the bladder neck in most of them. There's a small video of the technique of how we see the prostatovesical junction. We start opening up the bladder, and rather than opening him directly a wide mouth, we try and get inside the prostatic urethra to cut the bladder neck as close to the prostate as possible to preserve the bladder neck. And that gives us continence, better continence in the immediate early post-operative period. So you can see that we have gone inside the prostatic urethra, close to it, and the bladder neck is preserved, and the bladder neck is cut just inside the prostate. And if you preserve, the bladder neck preservation has been accepted as a method of improving early continence in these patients. See how small the bladder neck is. The other thing, if we can afford to do it, if the disease is not reaching close to the capsule, we try and preserve both the neurovascular bundles, and if not possible, then at least one side where the disease burden is less. Now, in preventing the neurovascular, preserving the neurovascular bundle, what we do is we do a high release. We start off near the puboprostatic ligament. As you can see, there's an accessory artery which was dissected laterally, and you can see that the incision is given near the puboprostatic ligament and then followed proximally and distally, and you try and preserve all the nerves either by clipping them or by dissecting them. The same thing is repeated on the other side. The importance of high release is that you can preserve maximum number of nerves that way. If you go laterally, then the chances are the quality of nerve preservation is little less. So high release has been said to be a factor in preservation of the nerve. Another important part is that when you are dissecting the apex, you need to go close to the apex to get the maximum length. For that, if you tie, in our experience, if we tie the DVC first, then the bunching effect that can lead to problems. We can't see the apex clearly. Most of the time, either the suture is not occluding the DVC completely, or you may take the part of urethra or part of the apex. So what we do is we cold cut the DVC once we have done the lateral and posterior dissection, and then with the sutures we take control of the DVC. Like the nerve preservation and posterior dissection has been done, you can see the DVC here, and the prostatic apex and urethra is going to be behind this. You increase the pressure up to 20 millimeter of in the laparoscopy, and that reduces the bleeding for the time being till you're cutting and suturing. And after the suturing, you can reduce the pressure back, the intra-abdominal pressure. So this way you can clearly see the apex, and you can maximize the length of urethra, and you're less likely to get inside the prostatic apex if the disease is at the apex. And once you have completely cut it and separated the sphincter part along with it, the chances of damage is less. While suturing, you must take care of two things. One, you should not start your suturing too laterally to take the nerves that you have preserved. And the second is that you should not go too deep to take the striate sphincter muscles, so that it may injure the muscle. So superficial sutures are taken, and the DVC, the bleeding from the DVC is controlled. This suture is not cut here, it is kept in the anterior, it's attached to the anterior abdominal wall, and it is going to be used subsequently. I'll describe in the next few slides. So you can see the DVC is completely. Now you can start at the apex. You see the amount of the length of the urethra that you can get by this method. You can see the veru and cut distal to the veru. This maximizes the length of the urethral stump that you get, which is said to be responsible for improving the continence in the immediate post-op period. Maximizing urethral length, I've already told you. Now the posterior reconstruction is done in the standard way, and our urethrovesical anastomosis is usually done with the same suture that we have used for this. Once you do the posterior Rocco stitch, the same stitch you can use to start off with your urethrovesical anastomosis. Can I get a little bit of time? If it's okay.
Yes.
Thank you. See, the same suture which we use for the Rocco stitch is being used to start off with the urethrovesical anastomosis, and it is taken to the other side, another suture. So this prevents us to use more number of sutures, and we can most of the time do the whole anastomosis with 2 sutures, and sometimes we need a third one. Bladder neck reconstruction, we prefer the tennis racket way rather than the fish mouth, because then the part which you suture, the extra length that you suture of the bladder is anteriorly, and the anterior leak is always better than posteriorly. Reducing blood loss by increasing the intra-abdominal pressure, especially during DVC ligation, and when doing the pedicle, using the clips and sometimes the sutures. In the end, what we do is the suture that we use the DVC to tie the DVC, we use the same suture to suture it with the anterior part of the bladder that we have dissected. So that leads to the anterior reconstruction and gives support anteriorly as well. And that anterior support also aids in the continence part of it.
Okay. So Dr. Samit, these are all established procedure. What is your center's improvisation? Most of the literature now says.
Sir, most of the literature, apart from this, says that Ritzius sparing is one more procedure that aids in the early incontinence. Whatever the literature has said, you need to do it yourself and see the results.
Yes.
So what we have done is we have combined all of them together in localized patients. Because earlier, see, in our setup, most of the time, more than 50% of the times, we get a T3 disease, a locally advanced disease. You don't get this. So that was not possible. So our earlier patients didn't have very good continence post-operatively, and we had to do adjunct procedures. Since for last 1.5 years, we have started doing all these procedures in these patients. That has drastically improved our immediate post-op continence.
Yes. Division and then ligation is now practiced by more than 50% who are doing this radical prostatectomy. It reduces the incidence of incontinence.
All of the surgeons who have been doing robotic radical process, they have their own way of doing all these steps.
Yes.
We combine all of these to improve, and we have done 72 patients so far. I couldn't complete it. And we have the data of 6 months now, which is mature, and our early post-op incontinence, that is at 4 weeks, is about 87% continent, less than 1 pad. So that ways we have improved our own continence rate.
The 4 point you mentioned in the early counseling, that is also very important, and that the real expectation of patient is very important.
Yeah, counseling pre-operatively is very important.
So you said that we have improved our incontinence rate by doing these procedures. They were already done before also. How you improve your, because
nobody
3 months, 4 months already there is a stress incontinence. How long you follow these patients? Late Or
We have followed them up to 6 months now, most of our patients, some are left. We are planning to do the follow-up till 1 year and see at the end of 1 year, because it is said that till the end of 1 year, the continence improves in RARP patients. So once we do that, then we'll present our data.
put them some drugs or not?
No, we use phosphodiesterase inhibitors and Kegel exercises post-operatively. That's about it. No other drugs.
Thank you.
Thank you.
Next topic is long-term outcome of dismembered pyeloplasty in giant hydronephrosis caused by UPJ obstruction. Dr. Harish Pal from BHU Varanasi.
Good morning, one and all. I'm Rinaldo presenting in behalf of Harish from IMS BHU on long-term outcomes of dismembered pyeloplasty for giant hydronephrosis caused by UPJO. Introduction. UPJO is a common urinary tract anomaly causing hydronephrosis. Giant hydronephrosis is the presence of more than 1 liter or more than 1.6% of the body weight of fluid in the renal collecting system, or the involvement of more than 5 vertebral bodies. Till now, only 500 cases of gross giant hydronephrosis have been reported in the literature. Reported success rates of open pyeloplasty ranges from 86 to 97%. There is no published reports about the long-term results of the pyeloplasty in giant hydronephrosis. So our aim is to assess the long-term surgical outcomes of open pyeloplasty in patients with giant hydronephrosis. This was a retrospective study conducted at IMS BHU. It included 53 patients, in which 40 were children and 13 were adult patients. And it was conducted over a period of 10 years. All the patients with unilateral UPJO with giant hydronephrosis were included, and the urological anomalies such as VUR, ureteral duplication, and patients with ureterocele or cystic kidney disease were excluded. All the patients were approached with flank approach with anterior subcostal incision, and post-operatively ultrasound was done at 3 and 12 months and annually thereafter to assess the renal parenchymal thickness, and renogram was done at 3 months, 1 year, and 5 years to assess the improvement in the renal function. Coming to results, the parameters assessed were male to female ratio were 13:8:15. The operative time mean was around 2 hours. Hospital stay was around 5 days. This graph shows that the improvement in the ultrasound was around 88% and improvement in the scintigraphy was 79%, and symptom-wise improvement was seen in 77%. Complications occurred in around 6 patients who required repeated pyeloplasty in 7% of the patients and nephrectomy in 3% of the patients. This was one of the young child who presented with the distant abdomen with the lump in the, as shown in the first picture, and the second picture shows it has reduced after the PCN placement, and the ultrasound showing the dilated pelvis, and the last picture shows the DTPA scan of the patient showing non-functioning right kidney. The CT image shows the giant hydronephrosis of the right kidney of the same patient, and this is the intra-op picture of the right pyeloplasty showing the large dentin sac in the giant hydronephrosis patient. This was the comparison between the pre-op and the post-op hydronephrotic patient, showing that the post-operatively the renal parenchymal thickness has thickened marginally, markedly compared to the thinned out parenchyma pre-operatively. Discussion. In children, giant hydronephrosis results from the congenital urinary tract abnormalities such as UPJO, duplex system, or megaureter. The major problem for the treatment of giant hydronephrosis UPJO is that renal outcome after relief of the obstruction are not easily predictable. And GH UPJO is uncommon that there are only few reports on the outcomes after pyeloplasty in giant hydronephrosis UPJO. So recent reports, they indicate that significant improvement are possible following the pyeloplasty in kidney, even in less than 10% of the renal function, and nephrectomy is rarely required. Beck et al. In his paper, he assessed the long-term surgical outcomes of open pyeloplasty for EPJO in 25 children, in which renal function at 3 years was 33% and improvement in the renal parenchymal thickness was 4 mm. So children who underwent pyeloplasty before the 12 months of age, they experienced the more improvement in the renal parenchymal thickness compared to children who underwent after the 1 year of age. Saran et al. Also reported the overall success rate to be 91%. The limitation of this study was it is a retrospective cohort, so there will be some missing data and selection and procedural bias, and even still long-term follow-up is required. Concluding at 12 months of follow-up, surgical outcomes after the open pyeloplasty for giant hydronephrosis were satisfactory. There is significant improvement in terms of ultrasound, scintigraphy, and regression of symptoms, and still a long-term follow-up is required. Thank you.
In your study, any role of nephropexy and ureterocalicostomy in late presentation?
Whoever has failed, we have tried with repeated pyeloplasty only, sir. So, and who are not responded to that, some child have undergone nephrectomy. Ureterocalicostomy, we have not tried.
What are the causes of your redo pyeloplasty in these children?
Redo pyeloplasty, the causes or failed pyeloplasty, the major reason, and there is a fibrosis at the operative site, and if there is going to be dense adhesions at the operative site, and if there is small intrarenal pelvis, we have to go for.
You say it's a giant hydronephrosis, and even if you do redo pyeloplasty, why? It is the surgical fault or there is some cause in the patient?
And you were doing pyeloplasty for all patients irrespective of, because in the case that you showed, it was 0% function.
Yes, sir.
So even with a 0% function, you decided to do a pyeloplasty.
That was the study that even in less than 10% of the function, we can try for pyeloplasty in children of less than 1 year of age. That has got a, we can try with that and has got a good result. It was according to the literature, and also we have tried that.
There's no role of putting a PCN and then reevaluating the function after a month or so?
Yes, initially we have put the PCN. We have seen how much the function is improving, and after that we have proceeded with the pyeloplasty. Most of the cases we have avoided the nephrectomy compared to the pyeloplasty.
Okay, thank you.
Thank you, sir.
The last paper is management of cryptorchidism in adults, orchipexy versus orchidectomy. Our experience, Harishankar Singh. This paper is also from BHU Varanasi. You should have informed.
You should have
before
informed.
that, before.
See, we should have asked him present first then. It is not time to inform us.
And this is the last one in any case, so the session would close now.
The session will close. This is the last paper. So what should we do? So we'll give 0. Okay. Thank you.
I would like to thank respected chairpersons for their time and effort and discussion. And they can collect their mementos from Inspire Hall. Thank you, chairpersons.
Thank you.
Sir, please, you all have a photo, please. Yes, sir. Please snap. For the next moderated podium session, I would like to invite our chairpersons, Dr. Devinder Sharma, Dr. YPS Rana, Dr. Puneet Bansal, and Dr. Sanjay Garg, sir. Please come to the dais and start the session, sir.
Yeah, good morning, everyone. The first speaker is Dr. Mahesh Joshi. Incidence of de novo erectile dysfunction in pelvic fracture urethral injury after urethral reconstruction. Dr. Mahesh Joshi, please.
Good morning, all of you. I am Mahesh Joshi from SMS Medical College, Jaipur. And my topic is incidence of de novo erectile dysfunction in pelvic fracture urethral injury patients after urethral reconstruction, a prospective observational study. Coming to the introduction, posterior urethral injuries are most commonly associated with pelvic fracture with an incidence of 5 to 10%.
Excuse Mahesh, slides नहीं आई आपकी.
The literature recognizes an association between pelvic fracture urethral injury and erectile dysfunction. It is difficult to differentiate between ED due to PFUI and de novo ED due to delayed urethroplasty, unless patients are assessed for ED before and after injury, as well as before and after repair. Next slide. Not good. De novo ED is a non-complication of urethroplasty and is largely underreported. So we conducted a study in patients with PFUI using the 5 items IAF-5 score to assess the incidence of de novo ED and its correlation with 3 parameters named age, length of urethral defect, and surgical steps performed during urethroplasty using a progressive perennial approach. This was a hospital-based prospective observational study carried out in Department of Urology, SMS Hospital, from May 2019 to January 2020. 31 patients aged 18 to 60 years with pelvic fracture, urethral injury, and with the normal preoperative erectile function as assessed by IAF-5 score were found eligible for the study. These are exclusion criteria. Patients with inability to understand the IAF-5 score, patients having diabetes mellitus, ischemic heart disease, pre-existing ED, prior failed urethroplasty, patients who are not engaging in sexual activity before or after surgery,
patients with recurrent urethral stricture disease, and patients with complications in post-operative period like UTI, surgical site infections. All patients underwent a progressive perennial urethroplasty at least 3 months after trauma in a single stage. A stepwise approach for urethral mobilization was used, consisting a complete mobilization of bulbar urethra, separation of crural bodies, and inferior pubectomy to accomplish tension-free bulboprostatic urethral anastomosis. Patients were advised to engage in sexual activity starting 2 weeks after PUC removal. We evaluated patients' responses with IIF-5 questionnaire before the intervention, as well as 3 and 6 months post-operatively to assess erectile function after urethroplasty. In statistical analysis, we did pair T and chi-square test. If we talk about demographic data, this is the age-wise distribution of patients. This is not properly.
Excuse me, just help me out. This is not working. Why is that changing on themselves? Jump हो रही है सब jump हो रही है
बंद कर क्लोज कर This is the distribution of patients.
Can you go back one slide from the age of the patients? Yeah.
This is the distribution of patients according to age group. This is the distribution of patients according to the length of the stricture. And this is the distribution of patients according to the management taken. If we talk about severity of de novo ED after urethroplasty, before surgery, all 31 patients had normal erectile function. At 3 months post-surgery, 18 patients had normal erectile function, whereas mild to moderate erectile function was diagnosed in 7 patients, and moderate in 4, and severe in 2 patients. At 6 months post-surgery, 22 patients had normal erectile dysfunction, normal erectile function, 6 had mild to moderate, 3 had moderate, and none of the patient was diagnosed with severe ED. There was a statistically significant decline in IAF-5 score at 3 months after surgery in all age group, but statistically significant recovery was found only in age group 20 to 29. Similarly, there was a statistically significant decline in IAF score at 3 months in patients with more than 2 centimeters stricture length, and significant recovery was found in same group. Patients underwent PPU with crural separation with inferior pubectomy. There was significant decline in IEF-5 score at 3 months after surgery and significant recovery at 6 months after surgery. Coming to the discussion, Mandi was the first to comment on ED after arthroplasty in 1993, reporting a permanent ED rate of 5% after anastomotic repairs. There was a statistically significant decline in the mean IEF-5 score in all age groups at 3 months after surgery. However, statistically significant improvement in the recovery of the EF at 6 months was found only in patients aged 20 to 29 years. Zai et al. Showed similar results, suggesting that young age may be related to recovery of erectile function. In our study, 42% and 29% of the patients reported ED at 3 and 6 months, respectively. Few et al. And Carlton et al. Found that men with longer defect may require intracrural space development and inferior pubectomy, increasing the risk of ED. In our study, statistically significant decline in mean IEF-5 score was found at 3 months in patients whose stricture length was more than 2 centimeters and who underwent PPU with crural separation with inferior pubectomy. However, statistically significant rebound in mean IEF-5 score was observed after 6 months in these patients. Limitation of our study is that it was a single center study and surgery was done. In conclusion, it appears that probably initial trauma and its severity are not the only responsible factors for ED in patients with PFUI. EF should be assessed and documented in each patient before urethroplasty. Patient undergoing progressive perineal urethroplasty for PFUI may develop de novo ED postoperatively. Patient's age, urethral defect length, and steps performed during urethroplasty can also lead to increased chances of postoperative ED. Thank you.
Okay, Mahesh, whatever the assessment of ED was done in postoperative, it was the subjective finding. No objective evidence or any study was performed like Doppler or other thing?
No, sir. It was subjective findings, sir.
Only subjective?
Using IEF-5 score only.
Okay. And pre-op also, it was only IEF score?
Only IEF-5 score, sir.
No difference? Okay. And according to you, all the patients, they were normal, means after 6 months, nearly after 6 months. Only few were having mild to moderate?
Yes, sir. Only.
Thank you.
You had mentioned in your conclusion that one of the factors is steps performed during surgery, which affect the recovery of erectile function. What are the steps you feel are important while operating so that we can reduce the chances of erectile function dysfunction after surgery?
Sir, if there is extensive dissection, there will be more chances of erectile dysfunction. So,
what do you mean by extensive dissection?
Sir, like to achieve tension-free anastomosis, it may be required to crural separation.
Yeah, you have to do extensive dissection
or inferior pubectomy.
Progressive perineal means the same. We have
Yes,
to
sir.
do all these steps if it is at all required in more than 2 centimeters.
Yes, sir.
So,
and the 2 patients that you had with the severe erectile dysfunction,
yes, sir.
What are the age of those patients and what are the reason you think in those patients who had more erectile dysfunction in first 3 months after surgery?
Sir, these were in young age group, sir.
Both were young age group.
Both were young. It may be due to extensive dissection, sir. It can be.
Thank you.
Thank you so much.
Thank you, sir.
So now we'll call upon the next speaker, Dr. Harkirat Talwar. And his topic is clinico-pathological correlation of bladder cancer in young and old patients, cross-sectional observational study.
Good morning, everyone. I'm Dr. Harkirat Singh, and the topic of my presentation is a clinico-pathological correlation of bladder cancer in young and old patients, a cross-sectional observational study. Carcinoma of the urinary bladder is a disease of the middle-aged and the elderly. However, its incidence in the young population is around 0.4 to 1%. And due to its rarity, the natural history and prognosis of bladder cancer in young adults is not well elucidated. Some studies have reported a similar prognosis in young as well as the elderly age group, and many have reported that in the young patients, there is a decreased progression and recurrence rate. It also remains unclear whether this better prognosis is due to lower stage and grade of the disease in the young population, or is it due to the indolent nature of the disease in this age group. Thus, this study was performed and was aimed at studying the clinical and pathological characteristics of carcinoma bladder in patients younger than 40 years of age as compared to those above 40 years of age. And the reason for choosing 40 years as the cutoff was that in the previous studies, it had been shown that the epidemiological data changed gradually from 30 to 40 years and then from 40 to 50 years. The incidence rates gradually increase with age, and the incidence rates in more than 70 years is almost twice than that of 55 to 69 and 15 to 20 times than those of 30 and 50 years. Thus, 40 years was chosen as the cutoff criteria. It was a cross-sectional study done over a period of 24 months at the Department of Urology, AIIMS Rishikesh. All patients of any age and sex with biopsy-proven carcinoma bladder, new or follow-up, and who were willing to give an informed consent were included, and previous pelvic radiotherapy or chemotherapy and those who revealed a benign histology on TURBT, they were excluded from the study. During recruitment, the demographic and the patient data were recorded, and the medical history, examination, lab tests, urine examination, ultrasound, CT, and bone scan if required, all these tests were done. And after detailed pre-anesthetic checkup, a primary TURBT was performed. Deep muscle biopsy was taken and sent for histopathological examination. During TURBT, the cystoscopic findings were recorded on a bladder map, namely the size of the tumor, whether it was solid or papillary, sessile or pedunculated, or was it single or multiple. And on histopathology, the following factors were noted: whether it was a TA, T1, or a T2 tumor, the grade of the tumor, high grade versus low grade, whether any carcinoma in situ was present or not, whether the deep muscle was present, and if present, was it involved, and whether there was any histological variant. So there were a total of 268 patients included in this study, out of which 57 patients were younger than 40 years and 210 patients were more than 40 years. The mean age in the younger population was 31.4, with the youngest being as young as a 15-year-old girl. And more than 40 years, the mean age was 59.08. Most of the patients were male patients, and most of them belong to Uttarakhand or Western Uttar Pradesh. And the occupations were as follows: there were farmers and factory workers and cooks, and also many patients were laborers. The presenting symptoms, hematuria was the most common presenting symptom, with almost 90% patients presenting with hematuria. And the risk factors which were found in our study was that the tobacco use was the most common risk factor. However, there were also a significant percentage of people with occupational exposure to chemicals. And also, because of the chilly winters, there were many people who were using firewood smoke. So the excessive exposure to smoke, as well as the drinking water, which was heavily contaminated by chemicals, could also be a risk factor. In imaging, to our surprise, the younger patients also, to the tune of 35 to 40% of younger patients, they presented with a muscle invasive bladder cancer as opposed to previous studies. And also around many patients, even metastatic patients and no disease positive patients were present. The cystoscopic findings, again in the young population, around 46% patients had solid tumors. There 50% patients had all sessile tumors, and there were also around 34.5% patients with multiple tumors, and around 70% patients had more than 3 centimeters of tumor in the younger population. This data is contrary to all the previous studies, which show that the young population, they present with a low grade, low stage, and a small tumor. The histopathological results revealed that the deep muscle was involved in 36% of patients, and the high-grade disease was present in 58.6% of patients. There were also variant histology, which was found in the young population. Urothelial squamous differentiation was seen in 10%, and urothelial with sarcomatoid differentiation was seen in 1 patient. Coming to the staging and grading, as I told, that 36% had an MIBC. Also, the patients who had a non-muscle invasive bladder cancer, over half the patients, they had a high risk NMIBC. T1 high grade was present in 22.4%, and TA high grade, there was no TA high grade. The patients were managed based on standard institutionalized protocols. And we also lost 4 patients who were metastatic younger than 40 years. Thus, coming to the discussion, the results of the current study are in contradiction to the previous reported studies, and this may signal a recent trend change in the epidemiological distribution of bladder cancer in this age group. At our center, which caters mostly to the population of Western Uttar Pradesh and Uttarakhand, a total of 325 patients were treated, and out of which 58 patients were younger. This is the distribution of the patients. And as you can see that most of this lie along the Gangetic plains. So a very important factor could be the heavily contaminated drinking water. The most common risk factors in our study were smoking and occupational exposure to heavy metals, and the others being the firewood smoke which they use, and also the drinking water. All the previous reported studies showed that in younger population, to the tune of 80 to 90% are non-muscle invasive bladder cancer. However, in our patients, only 50 to 60% are non-muscle invasive. And also the earlier studies showed a lower recurrence in progression rates, which is not true in our case. There were many muscle invasive bladder cancers and also many metastatic patients. In conclusion, incidence of bladder cancer is on the rise in the northern belt of India along the Gangetic plains, especially in the younger age group, and high exposure to smoke via smoking or burning firewood and exposure to heavy metals are the major risk factors. Majority of young patients had a high-grade disease in presentation, and a large subset had muscle-invasive bladder cancer, contrary to previously reported studies. More randomized prospective studies are required to clearly elucidate the clinicopathological biology in this age group for the early identification and management of patients with worse prognosis. Thank you.
Thank you, Arpit.
Thank you.
So you mentioned that the trends are changing and you mentioned that the trends are changing and more of younger population is nowadays suffering from this CA bladder.
Yes, sir.
Okay. So as you mentioned that in smoking, you mentioned whether they are smoking tobacco or this firework. Is it the same?
Sir, we did not differentiate. We just had the risk factors. We both.
But as it is said that tobacco, which is containing this benzene ring and other chemicals, they are known for this has a etiological role in CA bladder.
Yes, sir.
But what about smoke from the burning firewood?
Sir, that we just it is just a postulation or a hypothesis that that could be a risk factor. However, we did not study what are the chemicals in the smoke which might be causing bladder cancer. Just a relation was found that this could be a risk factor.
Same way you mentioned about the water part also, that
Yes, sir.
contaminated water.
Those
and
also would require further studies to test what chemicals are present in the Ganges River.
because in Ganges River nowadays there is much study over the bacteriophages also, apart from the chemicals.
Yes, sir.
So can there is a possibility that these bacteriophages and other bacteria present in the water can that can cause
Yes,
it?
so that could be a possibility, as well as the heavy metals like cadmium, zinc, and all which are present. I was studying the literature, sir, on the heavy metals in Ganges River. It is a lot of, it is a pollutant, and that it is just a postulation, sir. So all these risk factors which we have in our study, they need further studies to actually have a causative role.
And when we talk about the water,
Yes,
so like you're hailing from Uttarakhand, there the water is comparatively, I would say, cleaner when it is near to the drilling down from
Agreed, sir.
Gangotri
Yes,
as,
sir.
as it
Yes.
flows down. So there is no comparative or any study that as it traverses down the land.
That would also be an interesting thing to study, sir, whether in the uphills versus down, what is the difference in the heavy metal toxicity and the rates of carcinoma bladder. Yes.
And according to your study, there is also a bias that only the laborers or the, I would say, the low socioeconomic class was included as the maximum number of patients belong to that, like laborers were there or.
Yes, sir. Almost 85 to 90% would be belonging to the low socioeconomic
So
status.
we cannot, maybe this postulation cannot be emphasized on the complete, entire society. The
Wider
demographically.
studies would be required,
Yeah.
yes.
You had mentioned in some patients, bone scan was done preoperatively. What are your indications of preoperative bone scan in CA bladder patients?
So it was not done as a routine. However, if the patients had any symptoms of bone scan or the alkaline phosphatase was raised, and also in T3, T4 disease, though not in the guidelines, but we generally do certain T3 or a T4 disease. a patient just to complete the metastatic workup, especially if you're planning a curative surgery.
You do a bone scan before doing a TURBT.
No, sir, before doing a radical cystectomy.
Before doing a
Doing a
radical
radical cystectomy. Yes.
And another slide you had mentioned about 80, more than 40 years of age.
Yes, sir.
Patients had 80% muscle invasive disease. Don't you think it is too high?
So that is what I was saying.
Almost 8 out of 10
Yeah.
patients, muscle
Sir-
invasion patients, it's a very high number.
Normally it is one
What's the
third
reason
around.
that-
Sir, I don't think so. It was around 45 to
It's
50.
80, in less than 40, it was 36%, while in more than 40, it was 80% was muscle invasive.
Sir, I'll just check. I don't.
Yeah.
Can you go back to the previous presentation?
Okay, but then.
ठीक
I
है,
just,
let's
just
go
find
for-
out. sir.
Fine, let's check.
Okay.
Thank you so much.
Thank you so much. Sir.
The next speaker is Dr. Sugam Godse. He would be talking on a comparative study of midstream urine culture and stone culture in patients undergoing ureteroscopic stone removal.
Good morning, sir. I'm Dr. Sugam Godse. I'm presenting a comparative study of midstream urine culture and stone culture in patients who underwent ureteroscopic stone removal. Now, ureteroscopy is a common procedure that is done in urology for a ureter calculus. And after stone fragmentation, it is quite common for patients with a sterile preoperative urine to develop a postoperative sepsis. This is because the urinary calculi are widely known to act as a bacterial nidus. And once these stones are fragmented, the bacteria are released from these stones. Stone culture is not a common practice in endourological surgeries, and preoperative urine cultures are heavily relied for the treatment of postoperative sepsis. This study was carried out from September 2019 to March 21 in the Department of Urology, Dr. SN Medical College, Jodhpur. A total of 50 patients were included in my study. Midstream urine sample were collected 7 days prior to the surgery and sent for culture sensitivity. In case they came out to be positive, antibiotics as per the sensitivity were given and a repeat culture was done. Once the culture came out to be sterile, a second generation cephalosporin was given 30 minutes prior to the surgery. Antiseptic preparation was done with a betadine solution, and the lithotripsy was carried out using a gravity flow irrigation with the semi-rigid ureteroscope. Once the stones were fragmented, they were collected and rinsed in 5 bottles of sterile 0.9% normal saline solution to wash off the surface contaminants and then crushed in the 5th bottle. This was the procedure described by the STAMI for stone culture. Now, all males and females with age more than 18 years of age and with the ureteric calculus, irrespective of the size, without any prior treatment were included in my study, while patients with a positive urine culture or taking a broad spectrum antibiotics or with a urinary tract anatomical abnormalities like presence of a PUJO, a ureteric stricture, were excluded. Also, patients having urinary stents were excluded because they are known to act as a source of infection. Out of the total 50 patients, the median age was around 55 years with a range varying from 18 to 78 years. The majority of the patients were male, 64%, with a male to female ratio of 1.78:1. Out of the 50 patients, 8 patients has a positive urine culture, whereas 21 patients has a positive stone culture. The most common bacteria isolated from the urine culture was E. coli, and in stone culture it was an Enterobacter. However, in both these conditions, one patient was having more than one organism. So we see that total 12% of the patients were having a positive urine and stone culture, but out of those 6 patients, only 2 patients had the same organism, which was E. coli. So the bacterial concordance was 4%, because only 2 patients out of the 50 were having the same bacterial ecology. 30% of the patient has a positive stone but a negative urine culture. 4% has a negative stone with a positive urine culture, and 54% of the patients are having both stone and urine culture negativity. On cross tabulation, the sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy of urine culture in determining the stone culture positivity were found to be 29, 93, 75, 64, and 66%. So we can see from these data that the urine culture in for determination of stone culture positivity has a poor diagnostic accuracy. Out of the 50 patients, 29 patients have got the same, were having same results. That is, in 27 patients, both urine and stone culture was negative, and in 2 patients, the same microbacteria was seen. But different results were obtained in 21 patients. Either growth was seen only in one culture, either stone or urine, or even if both were positive, they were involved with a different organism. So having a sterile midstream urine culture prior to any ureteroscopic removal of stone is a routine practice in urology. But despite the sterile culture, many patients suffer from urosepsis post-surgery. The microbiological ecology of stone differs significantly from that of the urine, and the stones are more likely to harbor bacteria than urine. Therefore, a negative urine culture cannot rule out infection. The urine culture also has a poor accuracy and a negative predictive value to predict the bacteriology of the stone. So we propose that the stones can be fragmented and can be cultured easily at the time of surgery without any additional, with minimum additional cost. And this will help to decrease the length of the stay in the hospital and overall expense of the treatment in case the patient develop a post-operative sepsis. Now, 2 similar studies were done by Gupta et al. And Songra et al. In my study and in both these studies, the most common bacteria in the urine was E. coli, but in stone, it was Enterobacter in my study and Pseudomonas in both these studies. Patient with positive urine culture was 16% and 24 and 45 in respective studies. With the positive stone culture was 42 and 51 and 65 in respective studies. Of particular significance are the last patient, that is patient with a positive stone culture but negative urine culture. It was 30% in my study, which was comparable with other 2 studies of 36 and 35%. These are the patients in which, despite a negative urine culture, when the stones are fragmented, they may develop urosepsis. Patients with diabetes, hypertension, and other comorbidities were included in my study. These patients, as we know, are already prone to develop infection, irrespective of the urine and stone culture report. Also, the size, the duration of symptom, and the composition of stone were not taken into consideration. So to conclude, I will say that the finding of this study reveals that the stone cultures correlate better with the bacteriological profile as compared to the urine culture. They can be easily obtained at the time of surgery with a minimal cost. And in case the patient develop a post-operative sepsis in a patient having a preoperative sterile urine culture, the stone culture can help in deciding the antibiotic to use, and it will minimize the hospital stay and the cost. Thank you.
Thank you, Dr. Sugam. So as you mentioned that stone composition was not evaluated.
Yes.
So don't you think that that also plays a role when we talk about infection during any stone disease?
The infective stones such as triple phosphate are known to
Definitely,
have-
yes. So if this would have been also seen when you're doing the stone culture, that a person harboring infective stone, he has more chances of urosepsis in the postoperative period. That should have been
Actually,
included in the study.
The sample size was only 50. It was done before the COVID era. So if I included those also, the sample would not have been statistically significant. So that parameter was excluded. Sir.
Okay, but it should have been included.
Yes, sir,
actually, huh?
it should have been.
And was there any, like you said, that whenever the urine culture was positive prior to the study, you gave an antibiotic for 7 days or so,
Yes,
and then repeat urine culture
Yes,
was done. So in 16% of patients, you said that you were having urine culture positive. So whatever the number was there, only 16% were having urine culture positive, or?
Yes, sir. So 16% were at the initial evaluation.
Initially,
16%
then-
had positive, and surgery was done only after
100% was
yes,
a
sir, sterile condition.
any history of recurrent infection in the patients prior to surgery? Because any correlation of that? You didn't mention about any history of recurrent infection.
Sir, actually, we only considered all patients, irrespective of whether they were having stones for a longer duration of time or the stone size, or
Any-
there were any obstruction or not. We included every patient.
No, you mentioned about only 2 things: ureteric stricture or PUJ
Yes, sir.
obstruction,
Stricture
as
and any
maybe,
anatomical
yeah,
abnormalities, yeah.
but not about recurrent UTI
No, no, sir.
or previous stone disease, previous procedures.
These are very important factors.
Yes.
Okay, and sometimes
So previous procedures we have included.
only stenting.
The patients which are having no history of any previous surgery were included.
As a matter of policy, you do any patient who comes to you with ureteric stone, for 7 days prior you do a urine cultures,
Yes, sir.
and after 7 days you operate.
Yes, sir.
The patients who are having refractory pain, during those period, what do you do?
Sir, if the pain is so severe, so we can.
Because
either go
ureteric
for
stones
the-
patients sometimes can have refractory pain.
Yes, sir.
See, basically, when we talk about ureteric obstruction, it has been said that if there is a total obstruction on that side, then it is detrimental to wait for such a long period.
Sir, actually,
Only if it is a partial obstruction and the patient is not having pain or other symptoms, then only we can wait for maybe 5 to 7 days. Otherwise,
Sir, in the patients which are having complete obstruction, we diverted them either via DJ or a PCNN, but they were excluded from my study. Those patients which are having a previous stent in their system, they were not taken into the study.
and sometimes then it's a bias because sometimes when there is a total obstruction or patient comes with severe colic, it has been seen that his urine is infected. Or at that time, we many times find that the system is itself infected, pyelonephritis or so.
Yes, sir.
That's
Then
why
we have-
patient present with severe features.
Yes, sir.
Thank
Dr.
you.
Sugam.
Thank you so much.
Hello.
Yeah, please,
please,
Dr. Sugam, a question from the audience.
Can you tell me what were the energy source that was used during the evaluation?
Sir, in upper ureteric, we avoided the pneumatic. Basically, we use the laser, and in the lower ureteric stones which were impacted, we use a pneumatic lithotripsy.
Do you think whatever sample you will get after the URS with the laser that require further crushing?
Sir, actually, in the laser, we didn't do stone dusting. We only did fragmentation. So they were more than 1 mm, and we collected all fragments, whether we did a pneumatic lithotripsy or a laser lithotripsy, and they were sent for culture analysis.
Till which ureteric level was your study included? In upper ureteric also you did a
Sir,
URS?
yeah.
Or in
Sir-
you included flexible scopy also?
No, sir.
Only
semi
rigid.
semi-rigid. Yes.
So lower ureteric stones you're talking about, or upper ureteric also?
So upper also we did, sir. We
But
use
they
a-
can migrate to the kidney?
So 2 stones in my study migrated to the lower calyx, and we converted the procedure to PCNL. And those stones were also retrieved and sent for culture analysis.
Thank you so much.
Yes.
So now we invite upon next speaker, Dr. Pradeep Nayak. He is talking about the role of laparoscopic assisted percutaneous nephrotomy for stones in ectopic pelvic kidney.
Good morning, sir. Dr. Sridhar, I'm speaking on behalf of Dr. Pradeep from IMS BHU. The topic of role of laparoscopic assisted percutaneous nephrolithotomy for stones in ectopic pelvic kidney. Pelvic kidney is the most common form of renal ectopy, and the factors.
Just a second, Dr. Pradeep or Dr.
Sridhar.
Sridhar, your name is not mentioned in this. The 4 names are there: Pradeep, Sameer, Lalit, and Yashashvi.
Sir.
So, did you inform the organizing committee or the scientific committee for this?
No, sir.
Then we need to say, because either the presenter should be listed in the names that has been given on this.
Sir.
What we'll do, we'll do one thing. We'll proceed to the next paper. Meanwhile, you can just talk to the scientific.
Yes,
please. Sorry for that,
No,
but we have to take.
Okay.
So next one is Dr. Sandeep Kumar. His topic is delayed removal of double J stent due to COVID-19 lockdown, assessment of factors for encrustation and its management.
Good morning, sir.
We can't give marks.
No, not this one. Not this. Dr. Sandeep. Fourth one. Yes. So title of my study is delayed removal of double J stent due to COVID-19 lockdown, assessment of factors for encrustation and its management. DJ stenting is one of the most frequent urological procedures, requires DJ stenting to be kept indwelling for short periods. And long-term DJ stenting is associated with encrustation, calcification, and sometimes calculi formation also. Previous studies have reported encrustation rate of 9.2% at 6 weeks, 47.5% at 6 to 12 weeks, and 76.3% at more than 12 weeks.
Because of COVID-19 lockdown, many patients could not turn up for DJ removal, and a large number of patients are presenting with retained DJ stents. So in our study, we analyzed cases of retained DJ stents that could not be removed due to lockdown, and to assess various factors that are associated with stent encrustation rate compared to previous studies and its management. It was a retrospective analysis conducted in Department of Urology, IMS BHU, between October 2020 to June 2021. We had 62 patients, 47 patients with encrusted DJ stent, and 15 patients without DJ stent encrustation. So we included patients with a history of indwelling DJ stents and lost to follow-up on account of COVID-19 lockdown, and excluded long-standing forgotten DJ stents not related to COVID pandemic. For all cases, we did CT urography, except NCCT was done in few cases with renal function test or contrast allergy. And we used FECAL, that is Forgotten Encrusted Calcified System, proposed by Acosta Miranda et al. For classification of encrustation on a scale of 1 to 5, depending on the size, location, degree of encrustation. This is that classification that grade 1 is the linear encrustation on either end of the pigtail portion of the DJ. Grade 2 is the circular encrustation on either end of the pigtail portion of the DJ. Grade 3 is circular encrustation on either end, along with linear encrustation and encroaching to the uretral aspect. Grade 4 is the circular encrustation on both the pigtail ends of the DJ. Grade 5 is the diffuse and bulky encrustation completely encasing both pigtail and the uretral portion of the DJ. We assess following factors, that is age, gender, indication of stenting, duration of stenting, grading of encrustation, various urine parameters, radiological images, surgical procedures performed to extract DJ stent, postoperative stay, complication and morbidity of the DJ removal procedure. So coming to the results, in Group A, we had 47 patients, Group B, 15 patients. The mean age in Group A was 36.30, and mean age in Group B was 40.12 years. So these are the most common presenting complaints. In both Group A and Group B, flank pain or loin pain was the most common presentation, along with hematuria, irritative LUTs, recurrent UTI, and etc. etc. So this is the statistical analysis that is showing duration of indwelling stent, urine pH, UTI, history of stone disease, and known history of CKD are the significant factors that is showing p-value less than 0.005. And these are the various indications for DJ stenting that we did before COVID pandemic. So most common is the PCNL in both the groups. Other than PCNL, we had ESWL, pyeloplasty, ureteric implant, stone, stricture, URSL. And this is the table showing procedure we did in the patients who presented with retained DJ. So cystoscopy along with DJ removal. In Group B, all patients underwent cystoscopy and DJ removal. And in Group A, 29 patients underwent cystoscopy along with DJ removal, 7 patients cystolithotrity with URSL, 2 patients PCNL, 6 patients cystolithotrity, 2 patients combined procedure in the form of URS, cystolithotrity, and PCNL, and 1 patient underwent nephrectomy. So this was the protocol that we used. In all patients, we did X-ray, KUB along with CT scan. And patients with poor renal parenchyma, we also did DTPA scan to document renal function, and SOS nephrectomy when the renal function was less than 15%. And in patients with good renal parenchyma, patients with grade 1 calcification, for the distal calcification, we did cystoscopy and stent removal, and the proximal calcification, we did ESWL or PCNL depending on the size of the encrustation. And in the grade 2 and grade 3 calcification, we did cystolithotrity for the distal calcification and PCNL for the proximal calcification. And grade 4 and 5 were the most difficult one to manage. We have to do a combined procedure in the form of cystolithotrity, URS or PCNL. Coming to the discussion, COVID-19 pandemic and lockdown led to DJ stents being retained for longer than they were meant to be. And many studies have reported forgotten DJ stents in urinary system and risk factor associated with encrustation. To the best of our knowledge, this is the first study to report effects of delayed removal of DJ stents due to COVID-19 pandemic induced lockdown. And most common presenting symptoms in our study was flank pain followed by hematuria. In our study, encrustation was 5.80%, which is quite similar to previous studies. Like El Fakih and colleagues in a series of 290 patients, 141 stents retrieved and examined, discovered that 9.2% of the patients had encrustation at 6 weeks, and 47.5% had encrustation at 6 to 12 weeks, and 76.3% of the patients developed encrustation or calcification at more than 12 weeks. So stent encrustation and calcification are graded as per fecal scoring into 5 grades. Grade 1 distal calcification managed by cystoscopy and stent removal. Grade 1 proximal calcification less than 1.5 centimeter was managed by ESWL or PCNL, and residual fragments in ureter were removed by using ureteroscopy. Grade 2 and 3 encrustation over distal stent were managed by laser cystolithography. And for the proximal one, we went straight ahead with PCNL. Grade 4 and 5 calcifications are the most difficult ones to manage and required multimodal endourologic treatment. We had 2 patients in which combined procedure in the form of cystolithography, URS plus PCNL was done. In a study, Borboglu et al., all patients required 2 to 6 endourological procedure, that is average is 4.2, performed at 1 or multiple sessions to render them stone free and stent free. In our study, mean number of procedures were 1.23. 46 cases were managed by endourological approach, and just 1 patient had to undergo nephrectomy. Bukapatnam et al. Reported the one-step removal of encrusted DJ stents. If patient's general condition anesthesia fitness permits, single-stage surgery should be performed to avoid multiple procedures. In our study, 45 patients underwent single-stage surgery and 2 patients had to undergo stage procedure to get stone-free. In our study, mean duration of stenting, alkaline urine, UTI, history of stone disease, and history of CKD are the factors associated with stent incrustation. To conclude, DJ stent is to be removed as early as possible. Stepwise approach is to be used for the management of retained DJ stents. Stone protocol CT scan should be used to assess grading, encrustation, and calcification. And combination of endourological procedures are well efficient in managing such cases, and nephrectomy is rarely required. Thank you.
Thank you so much. This was a forgotten DJ stent. What are you? How do you manage these patients? I mean, did the patients forget or you forget? You forgot.
Sir, these are the patients we operated before pandemic, and
Okay.
after they left, and because of lockdown, they could not turn up to the hospital.
What are your methods? Do you call the patients?
Yes, sir. We
despite
Sir,
your calling,
while-
they didn't come.
Sir, while discharging the patient, we write a date on the discharge paper, like this is the DJ removal date. So because of lockdown, they could not turn up actually, and in between in the COVID pandemic, we are calling and reminding those patients. So after the lockdown got over, these patients turn up with these.
How do you call these patients? What are your methods and your institute?
Sir,
for the
we-
states?
on the while admission, we keep.
That is fine.
Yes, sir.
After they are discharged.
Yes, sir. After their discharge, we call them. We have on the discharge card, we write phone number of the patient.
No, he's talking about follow-up.
I mean, if you have called them after 6 weeks, let us presume.
Yes, sir.
If at 6 weeks they don't come, do you remind them?
Sir, at least once or twice we call them.
You call them.
Yes, sir.
Okay. And in one patient, nephrectomy was needed.
Yes,
Which
sir.
was that patient? And
Sir, that patient had, sir, I mentioned that that patient had grade 4 and 5 calcification. We did CT urography. There was, poor contrast uptake. So we did DTP, and the function was, I have not mentioned, the function was less than 50%.
pre-operatively, he was fine.
Yes, sir. He underwent something PCN or
was
something.
he a patient of CKD? Because you mentioned that in patient of CKD, chances of this was more. So at the time of first surgery, was his creatinine normal, or there was some derangement, or and what was the surgery? Was it a stone surgery?
PCN was done, sir. PCN was done.
After 3 months doing a nephrectomy just for a retained stent, it's very unusual.
Sir, he had actually grade 4 or 5 calcification. So whole
No,
kidney was
calcification is not a
encompassed.
criteria. Was it a pyonephrosis, infected system? Why was this function so deranged? Can you correlate? Because the first parenchyma at the time of first surgery, was it satisfactory or not? Because nephrectomy is a major thing.
Oh, yes.
For a simple.
Whereas PCNL, you have done a PCNL. And after 3 months, you do a nephrectomy for stent incrustation. It's very, very unusual.
And in all these cases, when the stent was retained, did you find any correlation between the type of surgery that was performed? Like you said, pyeloplasty, PCNL, URS, or any other surgery, any relation to the incrustation according to the first surgery?
Oh, no, so that we have not studied.
That is a very important thing because in a pyeloplasty, there are like it's a stone-free patient.
Yes, sir.
And according to all the possibilities, the chances of incrustation might be less in case of because a stone patient is always the possibility of recurrence.
Yes, sir.
So chances are more in that patient. That should have been studied.
Yes.
And one more thing, as you mentioned about COVID era, because we are talking about this COVID patients.
Yes,
So in all these patients, did they suffer from COVID infection during this period? And was there any relation to the COVID infection and this incrustation of the stent?
Sir, all these patients before operating, we did COVID test along with HRCT test.
No, not at the time of surgery or admission. I'm talking during this period when they had forgotten or they didn't turn up. Did they suffer from this infection?
So that we
That was not
document
evaluated. Okay. And any relation to the urine culture during this whole period of 3 to 6 months or prior to surgery? Sometimes it is possibility that the patient might be having recurrent infection during this period that leads to formation of infected stones or incrustations.
Yes, sir.
That was also not studied.
Sir, at the time of admission, we took history regarding that, sir. So most of the patient who had UTI, they mostly consulted at the local practitioner during the.
Because during those days, investigation was also not an easy task. No?
Yes.
Okay. Thank you. Thank you, Sandeep. So now we move on to the next paper by Dr. Rohit Kaushal. Robotic VVF repair, lessons learned. Okay. So this paper will be presented online. Can we go ahead with the presentation?
I'm really sorry. Am I audible, sir?
Yes.
Yes, sir. Sorry, sir. I'll be talking about robotic VVF and lessons learned
Just a
regarding.
second, you're Dr. Ritesh.
Yes, sir.
Your name is not mentioned in the.
Yes, sir. Sir, actually, the program was scheduled to be done yesterday, but we in the last minute changes was there during the program time. So we had already informed the scientific committee regarding unavailability of Dr. Rohit for this presentation.
Dr. Rohit is not there.
No, sir. So we have already informed the scientific committee that I would be presenting this, sir. We already mailed them, sir.
Whom did you inform?
Sir, we had mailed them. Dr. Rohit has mailed them, sir.
And did you receive the confirmation of this that anyone can present?
Sir, actually, sir, we had mailed the scientific committee in the as
That's true. You mailed it, but did you receive the confirmation affirmation of going ahead?
no, sir. Actually, we did not. So actually, the program was changed 2 or 3 days back. At that time, we had to. He was not available, so he had mailed them regarding it.
Just a second.
Yes, sir.
Could you talk to who? Presenter or I think they are also doing their job. They have come down and online तो कम से कम वो होना चाहिए ना First one was also कि यहाँ के दिन से that चारों पांचों में से कोई नहीं है तो sorry, Dr. Ritesh.
Yes, sir.
Because we don't find any of the like whatever names are mentioned,
Yes, sir.
and we are not finding any like anyone from this presenting. So
No
we
issues.
have taken a decision not to allow you.
Oh, yes, sir.
Okay.
Yes. Thank you.
दूसरे वाले है ना वो जो जिसको जिन्होंने बात कर ली he has talked to Anil. They have allowed him. Can I read it?
So with this, we come to the end of this session, and the organizers will move on to the. One and the same thing. No, when we allow one and don't allow another one. कि कोई इनमें से जो चारों पांचों है उसमें से होना चाहिए. ठीक है. You won't allow.
Thank you, respected chairperson, for the time and the effort taken. I request the chairperson to please have a snapshot.
Thank you so much.
Sir, you can collect your mementos from Inspire near the secretariat.
Thank you, sir.
So for the next moderated podium session 9, I request all the chairpersons, Dr. Vishwajit Singh, Dr. A.K. Jain, Dr. Prashun Ghosh, Dr. Gautam Chaudhary, and Dr. Ashwin Walia to please come on the dais and start the session. Thank you.
Good afternoon, everyone, and welcome to this moderated podium session number 9. I welcome all of you to this, and a quick update on what we need to do is speakers are instructed to finish on time, and we'll have one question each from the audience if required. Thank you. If there are any. So we can start the session. I invite the first speaker, Dr. Rudra Gorai, who will be presenting on utility and outcomes of angioembolization in urology practice, a single tertiary care center experience. Dr. Rudra. Has it been informed to the committee? It's been in.
because next one, yeah.
So like to call upon Dr. M. Rinaldo. He has abstract number POD 50 and 51. Is he here? From BHU Varanasi. From BHU Varanasi. So we can have his presentation, please.
Good morning, one and all. I'm Rinaldo from IMS BHU, going to present a paper on ureterocalicostomy for reconstruction of complicated UPGO in adults at tertiary care center experience. Introductions. Primarily, the management of UPGO is pyeloplasty, but ureterocalicostomy, which is anastomosing the ureter to the lower pole of the calyx, is indicated in recurrent UPGO with postoperative fibrosis, relatively inaccessible renal pelvis, and unfavorable local anatomic factors. So our aim of the study was to evaluate the long-term outcomes of ureterocalicostomy and factors predicting its failure. It was a retrospective study conducted in IMS BHU over a period of 5 years, which included 36 patients. The patients with lack of follow-up for at least 2 years were excluded. The parameters focused were baseline demographic parameters like age, sex, and the perioperative parameters and the complications. Failure was defined as additional procedures required post-operatively for persistent symptoms or the renal scan showing persistent obstruction at least 2 occasions in 3 months apart. The variables that affect the outcomes of ureterocalicostomy were assessed in terms of primary pathology findings, the patient's age, serum creatinine, the preoperative renal size with a cutoff of 15 centimeter, and renal cortical thickness with a cutoff of 5 millimeter, hydronephrosis grade, and the preoperative renal function with a cutoff of GFR of 20 ml per minute, operative time, blood loss, duration of hospital stay, and the postoperative complications according to the Cleveland's classification. We included the unpaired t-test for continuous data and features exact t-test for categorical data. The significance was kept at p level of less than 0.05. This table shows the baseline demographic data, which included male of 68%. The baseline serum creatinine was 1.1. The baseline hemoglobin was around 10.2 gram per deciliter. And in this table, we can see that the most of the patients had a GFR of more than 20 ml per minute and cortical thickness of more than 5 mm. The renal size on USG was less than 15 centimeter. And the most common indication for the ureterocalicostomy was failed previous pyeloplasty or endopylotomy, followed by secondary PUJ following the pyelothotomy or PCNL, small intrarenal pelvis, long segment ureteric stricture, and post-traumatic. This is the perioperative data showing the operative time mean of 150 minutes, blood loss of 320 ml, and duration of hospital stay of 5 days. Successful outcome was seen in around 69.5% of the patients. And the most common complication according to the Cleveland's classification was UTI, which is seen in 30.6% of the patients, followed by urinary leakage, small bowel serosal tear, and bleeding requiring transfusion in 1 patient each. So this table shows that GFR of operated kidney and cortical thickness of the operated kidney were statistically significant between the successful and failed cases of ureterocalicostomy. Discussion. Ureterocalicostomy is an established surgical option where straightforward pyeloplasty is technically difficult in cases of UPGO associated with long upper ureteric strictures or small intrarenal pelvis, post-traumatic or secondary PUJO. The key components of ureterocalicostomy, it include complete lower pole amputation and preservation of most of the periureteral tissues and blood supply of the ureter, widely spatulated mucosa to mucosa tension-free anastomosis. Regarding complication, the incidence of UTI, as we have seen, it is most common, and it is slightly higher because of the multiple previous surgeries with long history of DJ stenting. So the independent parameters for predicting failure were cortical thickness and preoperative GFR. Concluding, ureterocalicostomy is an acceptable salvage option with a satisfactory long-term outcome, and patient with a low preoperative GFR of less than 20 ml per minute and a thinned out cortex of less than 5 will have showed a poor outcome after ureteric calicostomy. Thank you.
Thank you for the presentation. And I just like to ask one aspect. Practically speaking, most often people who are doing ureterocalicostomy allude to the problem of a thicker cortical thickness causing technical difficulties and technical problems in the outcomes. So did you try to look into your technique of how you are managing, because your cortical thickness was more than 5 mm, had a better outcome?
Yes, sir.
Could you please explain as to why this may have been? Are you doing, what was the maximum size of the cortical thickness?
Yes, sir. If the cortical thickness is less than 5 mm, it will be because of the poor vascularity at the anastomotic site, which will lead to the ischemic strictures, which will lead to the failure rate, higher failure rates, sir. So we according to the study, it shows that at least a 5 mm thickness is necessary to give a successful outcome of the ureteric calicostomies.
Your data showed that you have included the post failure of the primary pyeloplasty probably and UPJ, endopilotomy, both you kept in the same category. So have you segregated and analyzed your data who had the failed pyeloplasty versus the endopilotomy, failed endopilotomy?
No, sir, we are not segregated that.
So any specific reason for putting both the patient in the same group? Because of failure of the pyeloplasty and failure of endopilotomy are two different categories. So any specific reason for keeping both the patient in the same group?
In this study, we didn't separate, sir. We have
Okay.
just combined and kept in the same.
One last question.
Yes, sir.
What happened to the patients who failed the ureterocalicostomy?
Yes, sir. We had around 11 cases of failed ureteric calicostomy. In that, around 6 patients they underwent long-term DJ stenting, and around 3 patients underwent nephrectomy, and 2 patients again we operated redo cases.
And in the failed group,
Yes, sir.
what was the major indicator of failure, or what was the reason why they failed? Did you
That's
have a
what,
look
sir.
into it?
If the cortical thickness is less than,
That is one of the reasons.
yes, sir,
Any
and
other reason
GFR,
did you-
if it less than 20, though that were mainly
So how
static.
many patients in your group
Yes, sir.
fell into that less than 20 and less than 5 mm?
Around 11 cases, sir.
All of only
Yes,
two criteria.
Yes, sir. 2 were significant. Yes.
Success rate was around 70%.
Oh, yes, sir. Success rate was around 75%.
From the audience.
One question from the audience, anybody?
Okay. If not,
Next, I think Dr.
Yes.
Ronaldo, you have to go for the next.
Yes, sir. Next presentation.
PCNL in solitary kidney, a single center experience.
Yes. So my next paper is on PCNL in solitary kidney, a single center experience. Introduction. PCNL is the treatment of choice for large and complex renal calculus, but the management in solitary kidney poses a challenge. Shockwave lithotripsy and retrograde intrarenal surgery have similar outcomes in solitary as well as bilateral functioning kidneys. Conversely, PCNL in solitary kidneys, they have got a higher morbidity rate. In spite of all the surgical complications, PCNL is a gold standard treatment in the solitary kidney and with preservation of the renal function. So aim of the study was to evaluate the safety, efficacy, effect on renal function and post-operative complications. It was a retrospective study conducted at IMS BHU. Between the Jan 2016 to June 2020, it included 23 patients, in which 10 had underwent a contralateral nephrectomy, 8 had non-functional contralateral kidneys, and 5 solitary functioning kidneys secondary to congenital agenetic kidneys. Patients with lack of follow-up of at least 1 year were excluded. The preoperative data included a basic demographic parameters and serum creatinine, hemoglobin, and the renal function assessed by the MDRD equation. Intra and post-operative data comprised of the stone burden, number of access tracts, drop in the serum hemoglobin requiring transfusion, operative time, stone-free rate, variation of the creatinine clearance, complication according to the Clevin's classification, and length of hospital stay. Post-operatively, serum creatinine were measured at POD1 and POD7, while the eGFR was measured at 6 months. And according to the stage of the CKD, the patients were divided into group 1 having GFR of more than 45 ml per minute and group 2 having GFR of less than 45 ml per minute. The Wilcoxon rank sum test and PAD t-test were used for parameters before and after PCNL, and student t-test and man-with t-test were used to compare the data between the groups 1 and 2. This is a table showing the basic parameters in our patients. Median age having for around 41, and the serum creatinine was 1.99. Median eGFR was 63.9. And among the two groups we have classified, group 1 included around 15 patients and group 2 were 8 patients. So this is a comparison between the preoperative and the postoperative parameters in our patients, which showed that a significant drop in the hemoglobin, which was statistically significant. And the other parameters were serum creatinine and eGFR, which were measured, which were not statistically significant. So in this table, we can see that the group 2, in which the GFR was less than 45 ml per minute, had increased number of punctures, the increased duration of operation. There were increased fall in the hemoglobin, and complete stone clearance in the single session was less, increased hospital stay, and increased Clavens 3 and 4 complication. And comparing the group 1 and group 2, we can see that the complete stone clearance in single session was lesser in group 2, and so the complications. So both were statistically significant. Discussion. Even though the stone clearance was low in the patients with higher stage of CKD, as we have seen the group 2, but overall the PCNL has got a higher stone clearance, that is around 78%, and it is cost effective. The complication of PCNL poses a primary concern in the solitary kidneys, and the most critical complication is uncontrolled bleeding, which might require angioembolization or nephrectomy. The bleeding requiring transfusion, as per literature, it ranges from 0.8% to 45%. In our study, it is around 10.9% for the patient required transfusion. But most of the bleeding were managed conservatively, and only 0.8% required angioembolization. L. Nahas et al. In his study, it showed the significant risk factors for severe bleeding were solitary kidney, Staghorn calculus, multiple tracts, and inexperienced surgeon. Kurian et al. In his study, he showed that patients with CKD undergoing PCNL, there was migration of the CKD in around 12 patients, and 8 patients required RRT. In our series also, renal replacement therapy was required in 4 patients, of which 3 patients were in the higher CKD group. So the higher CKD group, which is group 2, had more complications, and the requirement of blood transfusion was high. So regarding the effect on the renal function, Akman et al. Showed that renal function stabilized or improved in more than 90% of the patient in solitary kidney. And our study was also consistent with that finding, that most of the cases there were improvement or stabilization in the renal function. Concluding, PCNL is a safe and has a good stone-free rate in solitary kidneys. Even though with increasing stage of CKD, the rate of stone clearance decreases and complication increases. And the long-term follow-up renal function had stabilized or improved in most of the patients with solitary kidney after PCNL. Thank you.
In patients with solitary kidneys with the PCNL, after your stone-free, stone-free status has been confirmed,
yes,
what do you think should be done to these patients who would, in all probability, develop a stone again down the line? Would you still go ahead and do a PCNL, or would you, as a secondary procedure, would you counsel them something at the point of discharge? You had a solitary kidney patient who had a stone, you did a PCNL. The stone is a systemic disease, it's bound to recur. What did you do to those patients? Because he has a solitary kidney only. 4 of your patients landed up with an RRT.
Yes, sir. Basically, we'll counsel them for the stone diet chart and we have to do the metabolic workup in this patient so that we have to avoid the recurrence of the stone disease, and we have to check the renal function regularly at 6 months interval.
So, Dr. Rinaldo.
Yes, sir.
In your abstract, you have mentioned that all patients underwent radionuclide scans pre-operatively and 1 month post-operatively. Is this a standard procedure for all solitary kidneys?
Yes, sir.
in your
At our
department?
institution, we do DTPS scans regularly at 3 months post-operatively and at 6 months post-operatively, sir. But for the study purpose, we have included also the EGFR calculation by the MDRD.
Okay. And what percentage of patients moved from group 1 to group 2 at the end of your study period? As in CKD 1, 2, 3, progressing to CKD 4, 5. You gave a percentage, so I'm just wondering how many of them actually went in. Okay, you can't remember it offhand, I guess.
You showed in your data that serum creatinine probably it was the mean serum creatinine, no?
Yes, sir. It was
1.9.
1.9.
So what was the range that you have not shown? What was the highest range?
Just I didn't have the
Okay.
range.
So you do any kind of diversion, stenting or percutaneous before going the procedure?
Before PCNL, sir?
Huh.
No, we didn't do any diversion.
So up to what creatinine level you take patient directly for PCNL?
We see that the creatinine level has stabilized. We do 2 to 3 creatinine RFT levels.
That's what I'm asking.
Yes, sir.
You stabilize, it means you have done some kind of diversion, either internal stenting or percutaneous nephrostomy.
Yes, sir.
So
We'll do initially DJ stenting, sir. DJ stenting, and we see that creatinine level has stabilized, and after that we take the patient for
with
PCNL.
1.9 creatinine, suppose somebody has 1.9 creatinine, do you take the patient for the stenting or going straight away for the procedure?
We see the pre-op previous levels of the renal function, and accordingly we decide. So if it is already stabilized, then we'll take for PCNL. Otherwise, we'll wait for the renal function to stabilize, and after that we'll take for PCNL.
Any question from audience?
Thank you, sir.
Thank you.
I think we can move on to the next paper by Dr. Harkirat Talwar, All India Institute of Medical Sciences, Rishikesh. Challenges, errors, and pitfalls encountered during the initial 3 months of setting up a urodynamic center, an institutional audit.
Good morning, respected chairpersons. I am Dr. Harkirat Talwar from All India Institute of Medical Sciences, Rishikesh, and the topic of my presentation is challenges, errors, and pitfalls encountered during the initial 3 months of setting up a urodynamic center, an institutional audit. The good urodynamic practice, as laid out by the International Continence Society, comprises of 3 elements: a clear indication for and appropriate selection of relevant test measures and procedures, precise measurement with data quality control and complete documentation, and accurate analysis and critical reporting of results. The working group from the ICS, it recommends that the person doing the cystometry knows the frequency volume chart, bladder diary, uroflowmetry, and the post-void residue prior to performing an invasive urodynamics. And also the maximum physiological filling rate should be body weight by 4. It is a standard, and suggests that a non-physiological filling rate is standardized on the basis of the individual's patient typical voided volumes. Marking is done for the first sensation of filling, first desire to void, and the strong desire to void during cystometry, and also the permission to void should be clearly marked. And the standard cystometry is performed with a fluid-filled system with external transducers at the level of the pubic symphysis. Fixation of the catheters as close to the anus as possible and the urethral meatus. It should be fixed with a tape so that it does not come out during the study. And the rectal placement of a fully filled, fluid-filled open or a punctured balloon catheter to measure the abdominal pressure should be considered the ICS standard. It is to be done in the vertical position whenever physically possible, and a pressure flow study is done in the comfortably seated position for women and in standing, which is the preferred position for men. Immediate repetition of the test when doubt exists as to whether the test has answered all the questions or not, and also it should be repeated if there are any technical errors and artifacts. These are the guidelines laid by the ICS. The aim of the present study was to audit
the urodynamic practice at our institute done for first 3 months of this year. Audit is done by all the institutions all over the world in various fields, and it is the mechanism by which we see if there are any what we are doing wrong and how to correct it. So the SOP at our department to do urodynamics is that we ensure that all the equipment is set up. There should be a sterile urine culture mandatory. The patient should have passed stools, and if the rectum is loaded, we give enema. And urodynamic questions should be identified. This is the key step of performing any urodynamics. And patients' vitals are recorded, and only those stable patients undergo the procedure. Ensure the UDS test form is given to the patient, and he has understood what is the procedure is, and what is to be done for how long, and what the complications could be. So in the first 3 months, we performed 31 UDS. At our institute, we have the facility for conventional video urodynamics as well as ambulatory urodynamics. In this, 9 were conventional UDS and 22 were video urodynamics. The results were calculated based on these 11 questions. One is whether the antibiotic was given or not prior to the procedure, if the sterile urine culture was ensured or not, was the SOP followed, if the proper zeroing to the atmosphere was done or not, if the patient's position was documented, if the catheters remained in place, if there was a cough present every 1 minute or every 100 ml of filling, if the recommended filling rate was followed, was the printed UDS report available, and whether the UDS question was mentioned or not, and if it was reported immediately. This audit was done by a member, a third member, which was completely unaware of the test. The test person was different from the auditor. So the results were as follows: that in all the patients, the preoperative antibiotic was given. In one patient, the sterile urine culture was not ensured because he had repeated urine culture positive. So it was done under antibiotic cover. The pre-procedure SOP was followed in all of the patients. However, we found that in only 3 patients, which is a very poor number, that the intra-procedure SOP was followed. The correct zeroing was done only in 11 patients out of 31 patients, and the patient position was documented only in 1 patient. The catheters, they remain in position in 30 out of 31 patients. In 1 patient, it was expelled out because it was a patient with abdominal stoma, and the cough was documented on the UDS machine 21 out of 31 times. The recommended filling rate was followed in all the patients, and the UDS question was mentioned on the report form in only 4 out of 31 patients, and all the reports were done immediately. However, the printed UDS report given to the patients was done only in 11 out of 31. Others all were handwritten. So the problems which were encountered during the study were that the 7 patients, they had situational inability to void. So only the filling phase could be assessed and not the voiding phase. The electrode was out in 1 patient. The catheter expelled out in 1 patient. There were artifacts in 1 patient. The voided volume was more than the infused volume in 5 patients. And the PDET Qmax was misinterpreted due to flu artifact in 1 patient. And the patient experienced autonomic dysfunction in 1 patient. Coming to the complications, 1 patient had fever and 2 had severe dysuria. However, they were mild in symptoms and resolved in 1 to 2 days. On follow-up, based on the findings of the UDS, when the treatment was started, around 14 patients, they had improvement in symptoms. 3 patients had partial improvement, and 11 patients did not have improvement in symptoms. And we could not contact 3 people. The common errors and pitfalls which we all encounter during a good urodynamic study are that the zeroing to atmosphere is many times not done to the atmosphere, but is done to the patient, as seen in this figure. And this is the first step and should be properly done. Second, the permission to void command is many times given during the peak of contraction of the detrusor, which is actually a part of the filling phase and not the voiding phase. So the precise moment of giving the command is also very important. The third thing is that with every cough, there is a change in the P detrusor, which should not occur. That means the calibration of the machine is not done properly. The fourth thing is that the P detrusor is fluctuating from the start. This means that the patient is actually shivering, and there is the room temperature is low, so that should be corrected. And many a times we do not write the history on the report, which should never be missed. And then there is many times there is a flow artifact that the flow meter is kicked by mistake, and there is an artifact, and this is results in a false recording of the Qmax. Sometimes the catheter comes out, so it should be properly fixed. And once the electrode comes out, the EMG activity is not properly recorded. And also many a times the voided volume is more than the infused volume. This could be because the patient is having polyuria, or there was also a mistake on the part of the person performing the test that the bladder was not completely empty prior to starting the UDS. So in conclusion, I would like to say that a proper urodynamic study should be done, taking all these factors into consideration. A proper history and physical exam, bladder diary, uroflow, and PVI should be recorded prior, and warmers should be kept in case of shivering. There should be proper fixation of catheters and electrodes. Proper reporting should be done. And the most important thing is that there should be maintenance of privacy and minimize patient embarrassment during the study. Thank you.
So it was basically the initial experience, and because who does the urodynamics at your center, yourself or technician?
So we do it ourselves. So there are technicians also, but they help us only with the patient positioning and the placement of catheters and electrodes. But everything else, right from the interpretation and reporting, everything is done with the residents.
Okay. So have you had any? I saw your all the probable what encounters you day-to-day practice. Have you had any episode of syncope or giddiness during the procedure to any of the patient?
So we do not have any, no, sir, no syncope, but only one patient we had autonomic dysreflexia, sir, for a spinal cord trauma patient.
Dr. Harkirat, congrats on looking into a very often neglected aspect of a urology unit,
Yes,
the
sir.
urodynamic lab. So I want to ask you, I mean, sir has already asked you one question that I wanted to ask. So how have you changed your practice after this? Because you have really audited it well. So do you now have a checklist? Because you see, you are following all the pre-procedure SOPs,
Yes,
but
sir.
intra-procedure somewhere you're faltering.
Yes, sir.
Only in 3 out of 31 patients you have intra-procedure SOP.
Yes, sir.
So have you made something like a checklist to ensure that all those things are followed dynamically? That's why it's a urodynamic thing, right? So have you changed your practice regards that?
Yes, sir. So this audit was very important for our institution. We recognized all the pitfalls, what we had been doing wrong.
Mhm.
And subsequently, after 3 months, sir, now we have performed after this also around 80 to 100 UDAs.
Mhm.
And we have found that significantly the SOPs are now being followed, and we have changed our practice, sir.
Great.
Nice presentation, Akirat.
Thank you, sir.
One question which comes to my mind straight away. What are the indicators for your quality control as an endpoint? By which I mean, you've done a urodynamic study in a patient. He lands up with a UTI. So have you stratified or have you looked into your group, 31 patients? How many of them? Number one. Second question, why have you not stratified your study as per the indications for the UDS study?
Yes, sir. So your first question regarding UTIs, there was in this study of 31 patients, only one patient had a UTI, and he was not the patient, the same patient who did not have a urine culture positive, another patient. So the quality check we do is that though we have multiple sets of catheters, but we are forced to reuse them after doing an adequate sterilization. So that could be one of the reasons, sir, that we reuse the catheters. Others indicators are that we just ensure that the sterile urine culture is present and an antibiotic is given. And so the second question regarding, sir, sorry for the second question.
Why did you not stratify your study as per the indications of the UDS?
Yes, sir. There were various indications for all these 31 patients. However, we did not stratify them, sir.
Importantly, why I'm asking is,
Yes,
most
sir.
of us, most of the good high volume urology centers would do your UDS basically for an outflow obstruction evaluation, mostly.
Yes, sir.
Neurogenic setups, number
Yes,
two.
sir. Yes, sir.
Pediatric group, number three. So when you are setting up, these needs to be stratified very clearly, and the data that would come out can be interpreted in so many ways in terms of quality checkpoint control, because
Yes,
you're
sir.
setting the unit up. You are still, your SOPs are still evolving.
Yes, sir.
Right. Second issue, training of you guys, till you do it, it's fine. There will be a point in time when the work overwhelms you and there are technicians. So who's the number two? Or who's the fallback in case you guys are not available? So what about training of technician staff, other things. Third point, sterility check controls. So when you're formulating your SOPs, these need to be very clearly documented as a flow chart or whichever ways
Yes.
you think is appropriate.
So sterility check controls are being done, but technician training, they're also new users, so we are teaching them, but there is no parameter in which we check that whether they have learned or not. It is just very subjective, so no objective parameter to check the training of technicians.
So it should not be just the numbers of how many they have done it, but actually
Yes, sir.
it should be supervised by a mentor, probably a postgraduate.
Yes, sir. Yes, sir.
Interestingly, 22 out of your 31 patients had video urodynamics, and that's not the standard practice in most urodynamic units. Would you explain why?
So that was the reason because there was a thesis going on in our department. So because of that, we had to. Yes, so that was the reason. Yes.
All right.
Thank you, sir.
Any question from
Any
the
questions
audience?
from the audience? We have one question. Give him a mic, please. If you could introduce yourself.
Yeah, I'm Dr. Siddharth. Hi, Dr.
Good
Hackett. Great work. One question is already pointed out by Dr. Ashwin. 22 were video UDAs, right? So which urodynamic machine do you have in your center?
So we have the MMS, the medical management system.
MMS. And which chair or the thing that you use for the patient?
So that I'm not sure of. The chairs.
So where do you place make the patient sit?
So there's a chair.
There's a chair.
Yes, sir.
So it's compatible with the video UDAs. right?
Yes, sir. Yes, sir. Yes, sir.
Okay. Thank you.
Yes.
Thank you. Thanks.
Moving on to POD 53, outcomes of staged repair of adult penoscrotal hypospadias with buccal mucosa in stage 1 and tunica vaginal flap as second layer in stage 2 by Dr. Swarnedu Mandal, AIIMS Bhubaneswar.
Good afternoon, everyone. I'm Dr. Abhay Gaur. I'll be presenting this. Okay, let's start now. I'll be talking about outcomes of the staged repair of adult penoscrotal hypospadias with buccal mucosa in stage 1 and tunica vaginalis flap as second layer in stage 2. Often the results of the adult penoscrotal hypospadiasis are poor. We have been operating more than 10 of such patients in our hospital in a year, and we have seen that the availability, the results are very dismal because there is a poor local tissue which is available for such repairs, as patient has already gone 1 or 2 times the operation, and this has compelled us to use the buccal as well as the tunica vaginalis flaps. So I'm describing our technique in which we are doing the repair in a staged manner. In stage 1, we use buccal mucosa, and in stage 2, we use tunica vaginalis flap. So I would be presenting these 4 cases, which are the last 4 cases we have done. And these are all the penoscrotal hypospadiasis with ventral chordae, which presented to us in the adulthood. 2 of them were hypospadias cripple, already operated multiple times outside, not at our institute. In first stage, we do chordae correction, and the thin and the unhealthy urethral plate is excised. And then we put on a buccal mucosal graft of width about 2 to 3 centimeter. In second stage, which is undertaken after 3 months, a new urethra is tuberized over a 12 French silicone catheter with, if data is available, as a second layer. Then we place a tunica vaginalis flap as third layer and skin as a fourth layer. We use 40 or 50 PDS or Vicryl uninterrupted sutures, and we remove Foley's catheter after 5 days. So these are the pictures showing our stage 1 repair. In the first picture, we can see there is hypospadias with already having a skin scarring due to previous surgeries. The scar tissue is there at the urethral side. And in the second picture, one can see by the side view, there is chordae. The third picture is showing after this incision, circumcoronal incision, and mobilizing the skin, we have separated the corpus spongiosum and the urethra, and the unhealthy urethra is transected. And one can see in the fifth picture, we have put a buccal mucosal graft over it after incising the unhealthy urethra. And this is the outcomes of the last picture is showing the outcome of the buccal mucosal graft at post-op day 3. This is the result which we often see after 3 months. The patients come with us despite of giving adequate advice of keeping the skin moist, doing massages, the patient often comes us with this kind of picture where the buccal mucosal graft which we have placed is improper, scarred, and contracted. So because of these things, we have modified our technique, and while doing a second stage repair, we use tunica vaginalis flap. So you can see in picture 1, the tunica vaginalis flap is being raised and placed over the repair. Similar second picture, and the third picture which shows the completed repair. This is another patient which we can see we are harvesting the tunica vaginalis flap, and in the another picture we can see how we have placed it using interrupted sutures. This is after the available subcutaneous tissue closure and using skin as a fourth layer to close the repair. And this is in the series intraoperative. First picture is the intraoperative picture after the repair. Second is at the post-op day 1. The other one is at post-op day 5 when we have removed the catheter. Another is at post-op day, this is 30th day, yes. Post-op day 1 month, post-op 1 month, and the other one at the 3 months, last picture. So we had got 2 cases which had an excellent outcome. One developed ureterocutaneous fistula, one developed infection with complete disruption of the suture line. One developed superficial glans necrosis after the first stage, and he was managed conservatively with dressings. After the first stage contraction of the buccal mucosal graft was seen in the 2 cases, and overall we have achieved 50% of success rate. So these are the complications which we faced. Although we know that we have to limit our dissection to the specific planes, so not to avoid injury to the important structures such as the arteries and the other neurovascular bundles. But more there is chances of getting these injured because the facial planes are not defined in these patients because of the previous surgery and the scarring. So these are the complications that we faced. The glans necrosis, as you can see in the picture number 1, and the other one having the superficial skin necrosis, often said because of the subdartos layer which is not used with the plane which is not maintained using a dartos layer. And these are the 2 pictures which are showing the good outcomes. Often the patient always come with he wants a very good cosmesis, and we offer them another stage of scrotoplasty and granuloplasty to correct the cosmesis part. But at last the patient, if he is happy with his flow, then we are also happy. This is a shy patient which is micturating front of camera, and one can see. So to conclude, the stage repair gives a respectable outcomes, and we have modified our practice to use a 12 French Foley's so that it gives us enough space to drain the periurethral, this pericatheter secretions so that the infection rate decreases. We have used PDS sutures. We remove the Foley's catheter early at the day 5 or 5 to 7. And we have seen that they have given us a better outcomes than the previous 3 techniques which we're using. Thank you.
So you presented 4 cases.
Yes, sir.
And out of 4, 2 had a cripple hypospadias.
Yes, sir.
And the success rate was
Around 50%. Yes, sir.
2 cases it was successful.
Yes, sir.
So who failed? It was cripple hypospadias or your virgin case? Who failed?
Sir, surprisingly, one case which we had a cripple hypospadiasis, of whom I showed a video at last, he was a success. The other patient who were not crippled, but he also failed because of the complete suture line disruption that he faced earlier.
And you said that you close in 4 or 5 layers.
Yes,
yes. First layer is urethral, second is the dartos fascia.
Yes, sir. If
third
that is
was the
available,
tunica
sir.
vaginalis, fourth was the skin.
Yes, sir.
So how you closed the in cripple cases? Did you get the dartos fascia adequately?
So that is why I mentioned if it is available, we try to use it. If it is not available, then we use tunica vaginalis flap.
But that you could have stated very clearly because only you have 4 cases. It is not
Yes,
a
sir.
big
Yes, sir.
series. You know?
Yes, sir.
Okay.
Nice presentation. So I would like to ask you, use of 12 French Foleys, the rationale is good. But do you risk having a lesser caliber of urethra? Because generally in urologic,
Yes, sir.
urologic thinking, we always want a 16 French voiding.
Yes, sir.
Okay, that is one thing. And early Foley removal sounds like a very good idea. But when you actually come to do it, how many of us would want to remove a Foley's at day 5? And especially even after urethroplasty, when we're keeping it for at least 10 to 14 days. So how can you explain this?
Sir, I knew this question will be coming towards me because whenever I discuss, I face these questions. Problem with the 16 problem when we had this superficial skin necrosis, and we have in our earlier operated cases, we went on and we did a literature search. The glands necrosis has been never reported. There are few cases of a superficial skin necrosis, but the exact cause was not known. So we decided, we dig in some deeper, and we found out that the causes are often said to be because of the occluding dressings and not getting a space for the urethral secretions to get drained pericatheterally. So we use a good breadth, that is 2 to 3 centimeter, so that the lumen get wide enough, and 12 French catheter is placed so that these secretions, the infections which can happen later, these get drained out. And we ask our patients to gently massage and try to put out the secretions. Often, sir, in contrast to the patients, the pediatric patients which we have, and as the most optimal age is around 6 months to 18 months, these patients will always, despite of our maximum efforts, will have erections. So the erections also pose a very difficult this thing. Patient is on catheter often for 21 days. We give midazolam, we give this estrogen preparations, but still patients have erections. So these also put a pressure on the urethra, and we found out that these can be caused. So we modified our technique. We put a 12 French catheter, and we have seen that the outcomes are almost 50%. The results are almost with 15%. And I don't know about any such RCT or some case reviews which can say the outcomes are this good in an adult penoscrotal hypospadias.
Did you manage to finally calibrate the urethra in terms of the French? Did you do a cystoscopy and follow-up or anything like
Yes,
that?
sir. Yes, sir.
Imaging.
When the patient comes at the follow-up at 3 months, and he is not complaining of difficulty voiding, or if he complains of difficulty voiding, we tend to calibrate it with the Foley's catheter or the dilator, and we tend to know what is the caliber of the urethra now. So far we have not been, we have not seen any of the patients complaining of a stenosed urethra.
So which French would you calibrate with?
Sir, 16 French.
So a 12 French would finally end up as a 16 French. Is that what
Sir, this is what we have initially we have seen, because of we are using an ample breadth of the buccal mucosal graft 2 to 3, keeping the shrinkage also in mind, sir. So that why we have put this 16 French. Eventually the result will happen if we'll try to minimize our infection rate, and we will try to not to occlude these already devascularized structures, because vascularization here is a big thing.
Absolutely.
Yes, sir. So we all try to give minimum pressure on these structures.
Any episodes of a proximal urethral stricture, secondary?
Yes, can you?
Anastomotic stricture.
Anastomotic stricture. So far we have not seen, sir.
You didn't answer the question about early Foley's removal.
So similar, sir, for the same thing. When we see the patients, earlier we used to admit the patients for around 21 to 30 days, and we were leaving the catheters for around 21 days. But the similar episode happened with we saw a few patients who are putting the catheter, but they are not giving a catheter care. So as a result of that, there was increased chance of getting infection. So we tried to remove early catheter for them, and we saw in our results that in near about 5 to 7 days, the catheter can be removed and the patient still voids. And if at all we have a infection, we have a UTI documented, we can give antibiotics and it can be controlled. Because earlier we faced the problem of complete suture line disruption also. We have seen, and we have also seen patients getting infected and pus oozing out of their suture sites. So we try to minimize that. We are also trying to get a Bactiguard catheter, but these things are costly and patient obviously cannot afford these. So we have to also look after the cost effectiveness of these procedures.
Any questions from the audience, please? If there are none, thank you so much.
Thank you, sir.
We move on to the next, I think the last presentation. Dr. Siddharth Jain for a composite eosinophilic solid and cystic renal cell carcinoma with renal angiomyolipoma in a patient without a tuberous sclerosis complex.
Good
Please.
morning, everyone. I'm going to present a case. I'm Dr. Ankush Modi. Composite eosinophilic solid and cystic RCC with renal angiomyolipoma in a patient without tuberous sclerosis complex. So what is composite tumor? Composite tumors are two morphologically and immunohistochemically distinct tumors which are in close proximity with each other with actual cellular intermingling between them with a common driver mutation. These are uncommon and very rare in the genitourinary tract. My case was a 22-year-old lady with a history of bilateral flank pain, which is more on the left than on the right side. She has no other history of hematuria, weight loss, or any other constitutional symptoms. There was no history of malignancy in her family. Examination revealed a vague mass which are palpable in the left lumbar region. Tuberous sclerosis workup was done, which was negative. We had done the NCCT brain, which was normal. Fundoscopy was done, which was suggestive of no retinal changes or retinal angiomas. We have not done the mutation study because of the financial restraint. Imaging with the CCT in abdomen revealed a bilateral multiple renal mass with fat components suggestive of angiomyolipoma and left side large renal mass, which are approximately 13 to 12 centimeter. These are CT images showing right side renal angiomyolipoma with left large renal mass. Because of the bilateral disease and left large angiomyolipoma, we decided to go ahead with the left open partial nephrectomy. Intraoperatively, it was a 15 to 12 centimeter left renal mass from the middle and the lower pole. Cut section revealed a grayish-white solid tumor. We can see in the cut section there was a grayish-white tumor with a different necrotic area in the lower pole. Microscopy revealed a composite tumor. That means two eosinophilic solid and cystic RCC with angiomyolipoma, which are closely intermingled with each others. RCC component has a tumor cells in alveolar and tubular pattern, which are immunopositive for CK20 and negative for CK7, vimentin, HMB, and 45 and Milan A. Similarly, angiomyolipoma component, which comprise less than 20% of the tumor, was immunopositive for SMA, HMB45, and Milan A. So, for discussion, composite tumors are two morphologically and immunohistochemically distinct neoplasms which are coexisting within the proximity of the same organ, but they have an actual cellular intermingling and a common driver mutation that results in a divergent histology from a common source. Brandwin and Gensier et al. In 2004 proposed theories explaining the collagen phenomenon. They proposed three theories. First in theory was a coincidental occurrence of two primary tumor in a common location. Another theory is a common carcinogenic stimulus altering the cellular microenvironment within the proximity of which two distinct neoplasm arises. And third theory was the presence of a first tumor alters the microenvironment within the organ, leading to development of the second adjacent tumor more likely. Coming to my case, eosinophilic solid and cystic RCC is a recently described renal neoplasm with distinct clinical, morphological, and immunophenotypical features, which is currently not included in 2016 WHO classification of renal tumor. There are only 9 case reports till now. ASC-RCC is characterized by solid and cystic architecture with epithelioid neoplastic cells having eosinophilic and voluminous cytoplasm with finely or coarsely granular stippling. It is seen almost exclusively in female patients with or without tuberous sclerosis complex. ESC-RCC is usually clinically indolent and exhibits a unique immunophenotype with frequent cytokeratin 20 reactivity. This immunoreactivity is unusual and typically not seen in majority of renal parenchymal neoplasm. Concomitant renal cell carcinoma and angiolipoma is rare with only 60 case reports till now. However, most studies have either synchronous malignancy or collision tumor, which many studies didn't have clear distinction between them. What is collision tumor? They are the tumors which are lying close in proximity with each other, but there is no cellular intermingling between them. There are only 16 case reports having both components within the same tumor mass, but none with ESC-RCC. So, for as a urologist, why this entity is important. The knowledge of clinical entity of collision and composite tumor is important for patient management. The lipomatous area of AML component may be mistaken for perinephric fat or renal sinus fat invasion in a classical RCC, which may result in upstaging of the tumor. A spindle shape predominant AML showing degenerative nuclear atypia can be mistaken for sarcomatous RCC. Epithelial component of AML may be represented as RCC. So immunohistochemistry for identification of AML is warranted if any unusual morphology is noted in an otherwise typical RCC patients. So for take-home message, diagnosis RCC in its variant with AML as a composite tumor is difficult and rare. These cases require lifelong follow-up for recurrence and progression of disease. Follow-up protocols can be individualized with progressive increasing gap between contrast-based imaging and ultrasounds. Pathological samples can be preserved and tested with newer genetic mutation kits as our understanding about this tumor evolves. Thank you, sir.
Thank you, Dr. Siddharth. One question. Since you've done a literature search,
Yes, sir.
what are the other types of composite and collision tumors you've
So
observed?
most common is in the respiratory tracts.
Say it again.
Most commonly is seen in the respiratory tract. The lung cancers, they have the most common one, which are
I'm specifically asking about kidney cancers.
So in the renal cells, we have clear cell and papillary RCC, which has been documented. Clear cell and AML, which has been most commonly documented in the patient with tuberous sclerosis complex. We already presented one case in 2016 with a composite clear cell RCC and AML, which are collision tumor.
What happened to the other side?
Sorry,
In your index patient?
So the patient has been on follow-up and repeat imaging at 1 year shows the persistent of AML in the opposite side, which we are following up. There is no increase in the size, and we're just following up the patient, and there is no recurrence on the left side of the patient.
And since you did a partial nephrectomy of the affected side,
Yes, sir.
the tumor per se seems very large.
Yes,
So how
sir.
much of a renal parenchyma will be left behind?
So
you?
there were approximately 4 to 5 centimeters of the renal parenchyma which was left. The upper pole was spared completely.
Okay.
Yeah, even I was alluding to that. Unfortunately, you don't have an intraoperative picture of the remnant.
No, sir.
So there's no way of knowing this pre-operatively, right? So
No, sir.
you can't
We
really.
have suspected there to be both RCC and AML component, but we didn't suspected it to be a collision tumor or composite tumor type.
Okay, and in your histopathology report, you did not talk about the margin.
The margins were negative.
So in follow-up, have you had any CT scan done for this?
Yes, sir.
patient?
We had done the CCT at 1 year of the follow-up, and it shows there is no recurrence on the left side, and that side there is a persistent of an angiomyolipoma which is at left.
But you have not inserted here in the presentation.
Yes, sir. Because I didn't have the patient outside CT, I didn't have the CT images.
Okay.
So
Then
that's
how
why.
many such tumors have been described in the literature?
Sir, the composite tumors, they only for the renal urological perspective, they are only 16 case reports that we have.
That was the with angiomyolipoma, you said.
Huh?
With 16 tumor with angiomyolipoma.
Angiomyolipoma with the clear cell carcinoma.
Okay.
And there's a new.
So what is the overall prognosis of such tumor?
So it is very rare, and the only case reports. The longest case series is about 8 cases.
Any question from audience?
If there are none, thank you so much. Thanks everyone for this session. Thank you all the chairpersons.
Thank you for sticking to time and for a healthy discussion. I think we can call it a day.
Yeah, thank you, chairpersons, for sticking to time and for a healthy discussion. As I told, can I request all the chairpersons to please come on the dais for a group photograph, please?
You just keep these papers here. Thank you.
So thank you, chairpersons, for this wonderful session. We still have about 8 minutes to go for the next session. So
One person withdrew this.
So good afternoon, everyone. This brings us to the last session of the day, that is moderated podium session 10. I request Dr. Sandeep Kumar and Dr. Sanjay Kumar, sir, to please take their places on the dais and start the session. Thank you.
कोई पोडियम सेशन है जो चल रहा था उधर बैठना है।
First presenter is Dr. Ankur Arya. He's from Max Specialty Hospital. Dr. Ankur Arya, please.
Second presenter is Dr. Keyur Patel.
Dr. Keyur Patel. Yes, please come to the desk.
Yes. Good afternoon. Good afternoon, respected chairpersons and my seniors and dear colleagues. I'm here to present a paper on buccal mucosal graft onlay technique for upper ureteric and uretropelvic junction strictures. So as we all know, a proximal ureteral and uretropelvic junction stricture is characterized by a narrowing that causes a functional obstruction to the flow of urine. This leads to various complications like stasis, pain, urinary infections, and eventually renal failure as well. Oral mucosal grafts consists of non-keratinized mucosa and is believed to have a specialized and optimal vascular characteristics. Buccal mucosal grafts are OMGs that overlie the buccal buccinator muscle in the cheeks. BMGs are easy to harvest and handle, are resilient to infections, and are accustomed to a wet environment already. Using buccal mucosa as a tube with onlay inlay graft placement for the treatment of complex ureteral strictures has been reported. Currently, the trend is changing to buccal mucosal graft or choice of onlay uretroplasty. Coming to my study, it was an analysis done from January 2015 to December 2020. The inclusion criteria was all the patients who underwent surgery for benign upper ureteric strictures and uretropelvic junction strictures using BMG onlay graft. These are the CT images, sir, showing gross hydronephrosis with long segment upper ureteric stricture, uretropelvic junction stricture, and the pelvis being completely intrarenal, which makes pyeloplasty a difficult procedure in this case. This is an image of intraoperative retrograde ureterogram showing complete cutoff at the level of proximal ureter. Here are the intraoperative images where the image 2A shows the laid open uretropelvic junction and the upper ureteric part. The previously placed degestant, which was 4 French, is visible in situ. And from 2B and 2C, we can see the buccal mucosal graft being anastomosed as an onlay procedure over the ureteral plate. These are again the intraoperative images of anastomosis with degestant in situ, the first one, and the last image showing a completed anastomosis. The results of the study, a total of 22 patients, 17 males and females with a mean age of 32 years underwent buccal mucosal graft repair of the proximal ureter and stenosis bar stricture of the uretropelvic junction. The mean length of the narrowing or stricture was 6.4 centimeters. The location of the strictures were proximal ureter was having stricture in 18 patients, uretropelvic junction stricture in 3 patients, and stricture involving the both uretropelvic junction as well as proximal ureter in 1 patient. In all the 4 patients with stricture at uretropelvic junction, the renal pelvis was mostly intrarenal, making it near impossible to perform a pyeloplasty. The buccal mucosal grafts were harvested from healthy areas and were sufficient to length to the bridge and gap in all the patients. There were no intraoperative complications. None of the patients needed blood transfusion. Immediate post-op period was uneventful, and post-catheter removal, all patients voided normally. Serum creatinine remained stable at 6 and 12 weeks after the surgery. Post-operative radioisotope renograms done 12 to 16 weeks later showed improvement in the function of the affected sites in all patients with adequate drainage. Urine cultures and serum creatinine at 12 months follow-up were normal. These are the comparison and clinical reports of various studies which used oral mucosal grafts. All the studies were of small sample size from 5 to 7, And most of the studies had no complications or minimal complications, and the success rate was almost 100 in most of the studies using BMG mucosal graft. The present study is a series of 22 patients with length of the graft used as 5 to 9 centimeters, and follow-up was up to 5 years. And there was no complications or donor site complications as well, with success rate of 100%. Coming to the discussion, the short segment strictures of upper ureter or UPJ can be managed by primary excision and end-to-end anastomosis in the form of piloureteroplasty or uretero-ureterostomy. But the problem lies if the stricture represents a long segment, where specialized surgical techniques are required to provide a tension-free anastomosis, including procedures such as renal mobilization with or without nephropexy, ileal replacement of the ureter, transuretero-ureterostomy, ureterocalicostomy, and even auto-transplantation of the kidney at times. The point to make here is the stricture portion of the upper ureter or uretropelvic junction is definitely insufficient to effectively drain the system, but it could still provide an ureteral plate with adequate blood supply on which an onlay repair could be performed with BMG graft. Recently, the technique of onlay ureteroplasty with grafts or flaps has been attempted by many reconstructive urologists, and outcomes I have shown were highly encouraging, with success rates near to 100% in most of the studies. The common sites of oral mucosal graft harvested are either buccal mucosal graft overlying the cheek and lingual mucosa overlying the tongue. The thick epithelium, high content of elastic fibers, thin lamina propria, and high capillary density are the beneficial for promoting revascularization of the BMG grafts. A study done by NOD initially reported on tubularized BMG interposition for the management of complex ureteral stricture in one patient with a traumatic loss of 4 centimeters of the middle ureter. But tubularized BMG grafts are not promoted eventually. In our series, the length of the strictures was long and definitely needed long grafts. The harvesting of grafts was easy and of desired length. The ureteromucosal anastomosis was easily performed, and the anastomosis covered with pedicle domental graft in all cases. So the conclusion remains, long segmental stricture of the proximal ureter and uretropelvic junction is often a treatment dilemma for most urologists, where using autologous patch grafts, namely an onlay ureteroplasty procedure, is an optional surgical case technique in such cases. Thank you.
Doctor, what was the total duration of the study?
Sorry, sir.
Total duration.
Sir, from 2015 to 2020, sir. 5 years, 22 cases were operated, and those patients are included in the studies.
Is there any long-term follow-up of this case?
Yes, sir. The patients operated in 2015 were followed up till 2020. So the maximum follow-up of the study is 60 months.
All doing well.
Sorry, sir.
All doing well.
All doing well, sir. Yes.
In this case, what do you suspect? What will be the source of the blood supply of this graft?
Sir, the capillary bed of the buccal mucosa is sufficient enough to revascularize with the ureteral mucosa and takes up the blood supply pretty well. Though that is the one thing which helps us using
that from the margin only.
Margin, sir.
But graft length is around 7 to 8 centimeters.
Yes, sir. So, but the width of the graft will not be wide enough. So, if it gets adequate supply from all the anastomose margins, the central part will not have any problem with vascularity, I guess.
What is the ideal size of buccal mucosa graft?
So 4 to 5 centimeters.
But here the length is around 8 to
6 centimeters is the average graft. Yes, sir.
Actually, it's quite surprising. You claim 100% success rate.
Yes, sir.
Which is not even mentioned for the standard pyeloplasty. And you are claiming that with buccal mucosal graft substitution.
Correct. So previously done studies over last 5 years, out of 7 studies which I quoted, 6 of them had 100% success rate with no
What was the
restenosis.
What was the follow-up in these studies?
Follow-ups, sir. Follow-ups were also pretty long, sir, up to 2 to 3 years. Can I display this? Oh, this is already an expert.
One more question, actually. Yes. How do you decide that for which case you will take buccal mucosa graft?
Yes, sir.
Or you will prefer some other technique like renal decensus or?
Yes, sir. No long upper ureteric stricture more than 5 centimeters, and uretropelvic junction strictures in the cases where the renal pelvis was intrarenal in most of the cases. So those cases where pyeloplasty was not sufficient enough, the ureteral plate was opened up and onlay buccal mucosal
For
grafting was-
internal pelvis, you don't prefer uretrocalicostomy or?
Uretrocalicostomy can be done. That is what I mentioned. This is an alternate surgical technique with better results. So,
But at your institution, you don't prefer that.
uretrocalicostomy also we do, sir.
Okay.
But if we have got a thin renal parenchyma in the lower pole, still it is better to go ahead with onlay buccal mucosal graft rather than doing a uretrocalicostomy.
Actually, if a paper thin lower pole kidney, it is easier to do a uretrocalicostomy.
Yes, sir. Where we have thick renal parenchyma, as I showed the CT image, sir, the renal parenchyma was thick enough all around, but still the entire pelvis was intrarenal. So those kind of cases we ideally picked up for the buccal mucosal graft.
So it's only length of the stricture basically.
Length of the stricture and
On which you
intrarenal
decide.
pelvis when UPJ stricture was there.
Okay, fine. Any question from the audience? Please go ahead.
So, congratulations on having a very large series of upper ureteric strictures. May I know what is the cause of stricture in these patients, in 22 patients?
Yes, cause of stricture, I guess 2 patients had tubercular strictures and all were benign. The inclusion criteria itself was benign ureteric strictures. So malignant we have not included, and other were primary uretropelvic junction strictures, and few patients had URS undergone previously. So iatrogenic strictures were also there.
So my question to you is, 2 had tubercular, right?
Sorry?
2 had tubercular strictures.
Yes.
So tubercular strictures are usually multifocal. How come they had an upper ureter is not the most common cause?
Selectively, these 2
Selectively,
patients were
okay.
having upper ureteric stricture.
Majority had primary UPJ.
Yes.
So why was primary UPJ 5 centimeters in length? It should be short.
Not primary UPJ, sir. Long ureteric strictures were 5 centimeters. Primary UPJs.
What was
with
the cause
intrarenal-
of 5 centimeter long upper ureteric stricture? That you had 22 patients. What are the
2
causes of that?
2 of them had tubercular and
Okay.
others had iatrogenic and
So 20 were iatrogenic ureteric strictures.
I'm not very sure of the causes, but there were iatrogenic cases as well as infective cases leading to.
Okay. And the second question I want to ask, I'm sorry. I want to ask is that you said the graft takes up mostly from the margin. Now the causes were iatrogenic and tubercular.
Yes.
So the ureter was already ischemic.
Yes.
So how do you support a 7 centimeter or 6 centimeter length graft? What was the width of graft that you took? You did not mention probably that. The
Mean
width of the
was-
graft. Width of the graft.
Width of the graft will be less than 5 to 6 mm or
5 to 6 mm.
or a half centimeter. Yes.
Or
Five-
what was the goal? What was the goal that you tried to make? What was the objective of the?
The objective was that only in cases of
No, the desired size of the ureter of the that you wanted to make.
Yeah, to make it tubular enough to drain, where most of the cases we have inserted 6 French or 8 French.
So you wanted to take only a you wanted to make an 8 French
Yes.
ureter. So the buccal mucosa is going to contract by a third. So if you make it 8 millimeters only or 8 French only, it's going to go down.
I'm just saying approximately it will be 1
Okay.
centimeter.
Okay, thank you.
Next presentation is Dr. Pranav Jasuja.
Good afternoon, everyone. Good afternoon, chairpersons and my dear colleagues. So my presentation today is a retrospective study, neoadjuvant chemotherapy followed by cystectomy in our center experience. And my guide will be Dr. Arvind Ellison. So coming to the introduction, more than 50% of the patient we have seen in a muscle invasive bladder will relapse and die from distant metastasis following surgery or radiation. Now, randomized control trials have consistently shown cisplatin-based multi-agent chemotherapy improve overall survival by 5 to 10%. And it is important to focus on early eradication of micrometastatic spread with perioperative chemotherapy. Now, the use of neoadjuvant chemotherapy is an attractive treatment option considering the general chemosensitivity of urothelial carcinoma and lack of neoadjuvant chemotherapy associated serious complications. Now, the meta-analysis of 11 trials consisting of neoadjuvant chemotherapy with 3,000 patients showed a reduction of in the risk of death of about 14% and survival advantage of about 5% over 5 years. There's another study by Grossman et al., which enrolled 307 patients, in which half of the patients underwent radical cystectomy and half of the patient underwent neoadjuvant chemotherapy followed by radical cystectomy. And it has shown the median survival has increased up to 77 months, and residual disease has shrunken up to 15% in those cases. So in these studies, the author concluded that neoadjuvant chemotherapy followed by radical cystectomy improved overall survival in a case of locally advanced bladder cancer. So in our study, we have retrospectively reviewed our series of patients who underwent neoadjuvant chemotherapy followed by radical cystectomy. Study was conducted between retrospective cases were collected from 2006 to 2020. 72 patients data were collected. Histopathology slides were reviewed to confirm the diagnosis, that is the invasion of muscle propria, and cystectomy specimens were also reviewed to see the rate of downstaging. A neoadjuvant chemotherapy was given as a planned 328-day cycle in which MVAC regimen was followed. Methotrexate, vinblastine, doxorubicin, and cisplatin was given, and dose and cycles were modified according to side effects. Then radical cystectomy was performed with bilateral pelvic lymphadenopathy and creation of ileal conduits and continent cutaneous reservoir. So my results are a total of 72 patients data were collected. The median age of the patients was 59.84, or we can say 60 years. And the male to female ratio was 5:1. Median duration of the neoadjuvant chemotherapy was 53 days. Out of my 72 patients, 19.4% completed all 3 cycles, 72% patient completed 2 cycles, and remaining 8% completed only 1 cycle. Then radical cystectomy was performed using ileal conduit in 84% patient and 15% in continent reservoirs. Post-operative period was comparatively uneventful. There were no major complications, and there were no major post-operative deaths also within 1 month of surgery. Up to 50%, the data was collected for a period of 15 years, in which 50% patient died during the follow-up period. Mean and median survival of the patient was 84.85 months and 91.0 months respectively. The data is showing. And after 5 years, 61% patients were alive. So in my discussion part, the micrometastatic deposit present at the time of diagnosis, but which were not detected by modern imaging, are believed to be responsible for relapses in radical cystectomy. Perioperative chemotherapy can eradicate these micrometastases. The stage of the disease at presentation has significant impact in individual patient outcome and long-term survival. Retrospectively, studies are also supporting my study. A study was conducted in which 1,000 patients data was recorded, in which 5-year and 10-year recurrence-free and overall survival rate in a lymph node negative disease was 85% and 82% respectively, whereas in lymph node positive disease, it was 35% and 23%. Due to poor prognosis of lymph node positive disease, and efforts have been made for early eradication of micrometastasis. As a result, neoadjuvant chemotherapy is an attractive option in these cases. It has already been used in case of solid tumor cancers like breast, rectum, and cancer. Another study with support is Splinkter and colleagues have also done this study, in which 5-year survival rate, 5-year survival for those who are achieving a major pathological response versus no pathological response was 75% as compared to 20%. In other study, 5-year survival advantage was seen in patients using same MVAC preoperatively, achieving less than pathological T3A stage in response to more than T3B. The 4-drug regimen was used by Southwest Oncology Group, in which again same MVAC regimen was followed. In this study, they have shown an increased rate of pathological completion rate, that is 38% as compared to 15% and surgery alone. Pathological completion rate is considered as benchmark for patients who achieve 5-year overall survival of 84%, in contrast to patient with residual cancer in bladder cancer in the bladder. In my studies, the toxicity or complications which was most commonly seen was granulocytopenia, stomatitis, and combined gastrointestinal complications were also seen. Other than MVAC regimen, alternate option is gemcitabine and cisplatin regimen that has also proven equally efficacious. Up to 50% of patients, which some are ineligible for cisplatin-based therapies, that is because of medical comorbidities, impaired renal function, poor Karnofsky performance status, or having a class 3 heart failure. In those cases, we can use carboplatin-used chemotherapy. Our results are at par with the other contemporary studies, that is European Organization of Research and Treatment Cancer and Medical Research Council, in which 976 patient records were calculated, in which 80% of the 491 patients completed all 3 cycles of chemotherapy. Now, over a period of 3 years, the survival rate of 5.5% was significant, was seen, which was not significant, but over the period when the study was conducted, when the data was collected over the period of 10 years, this same data became significant, up to 16% reduction in the risk of death of the patients in chemotherapy arm. The estimated 10-year survival in chemotherapy arm was 36% as compared to 30% in control arm. Another study which I have already mentioned, Southwest Oncology Group, in which they have seen the median overall survival in chemotherapy group was 77 months as compared to 46 months in cystectomy only patients. Another study supporting that, advanced bladder cancer, which again shows absolute survival benefit of 5% over 5 years and disease-free survival rates. Significant data was supported as platinum-based chemotherapy. Despite the evidence supporting neoadjuvant chemotherapy, it is continues to be underused. That's all.
Doctor, what is new in your study?
Nothing. It's a retrospective study which I have done.
It's already standard practice recommended in almost all guidelines.
Yes, sir.
So,
But still, it's not being followed in any stage.
okay. How did you got this number? The number of patient in your study?
Retrospectively, I collected data, sir.
It's a
And
just-
actually, my colleagues, senior colleagues were already following up the, already they were doing study. I also took part and collected the data.
The sample was not calculated before the study actually. You want to say?
No, total overall within a time period we just did, and 72 patients over 15 years took, we took data of that patients.
Second question, what was the complication rate during the neoadjuvant period and how much patient actually completed the course of neoadjuvant therapy?
Sir, overall, during my study, there were only 19% patient who completed all 3 cycles.
90%.
19.
Okay.
Mainly only 2 cycles they could have completed, 72% patients.
And did you have done a subset analysis of that patient versus those who not completed?
No, sir. I have not.
Any question from the house?
So my first question to you is that you have selected 75 patients over the past
Yes.
5 years or so.
15
years or so. So were there some patients who underwent upfront radical cystectomy, or this is all of the patients in your center usually undergo neoadjuvant followed by RC?
No, it's some patients like went straight away with radical cystectomy. It's a mixed set of ideas. Like some consultants straight away still used to go for radical cystectomy.
So your conclusion that neoadjuvant is underused could have been better proven if you have compared both of these groups of the past 15 years.
Yes.
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 Second question to you is, you said only 70% actually got 2 cycles and 19% got all the 3 cycles. So how do you decide who gets 3 cycles, who gets 2 cycles? When do you stop?
No, according to my data, only either the patient has died over the time period, he could not complete all the 3 cycles, or he has lost follow-up.
So 72% died after 2 cycles.
19%.
19%
only completed 3 cycles.
all
Yes.
the 3 cycles, then
Yes,
underwent
yes.
RC. Right?
Yes.
And 80% completed 2 cycles and then had RC.
Either they have lost follow-up, or because of extreme
If they
side
could have
effects.
lost to follow-up, then they could not have underwent radical cystectomy, right?
No, I could not collect the data of the patients. It's a retrospective study. Whatever data I could collect. And second is like we could not complete all 3 cycles in other patients because of the extreme side effects.
So that is what I want to know. Okay. My third and the last question would be that you are comparing CT scan, pre-chemotherapy CT scan, to the pathological report. Have you done a repeat CT scan to say that the tumor is actually downstage? Have you used the RECIST criteria for confirming the downstaging of tumor?
Sorry,
So the patient underwent a CT scan, then got chemotherapy, then underwent radical cystectomy. Now you say that based on the previous pre-chemo CT, that the size has gone down because now it's T3, it was T2 or something.
Yes.
But that is not right, no? Because CT is not the best investigation to say what the T stage of the tumor. So have you done a follow-up CT scan? What is the protocol actually? After how many chemotherapies did you do a CT scan, and after how many cycles or after what findings you send them for RC?
Actually, after full cycle of chemotherapy only, we have done a repeat CT in these cases.
Thank you.
One question related to the question Dr. Siddharth asked. In how many patients actually you found complete response after completing the neoadjuvant cycle?
After all 3 cycles of the chemotherapy.
Yeah.
In 15% patients we have found.
1-5.
What is the criteria of complete response? How do you assess for? What were the criteria for the complete response?
Downstaging of the tumor, we saw that in those
No,
cases.
down staging is different thing. Complete response is different thing. And actually, worldwide data is around 20% of complete response, and yours is around 15%. Can you explain why this is discrepancy? And obviously, what is your criteria was complete response?
Sorry.
Okay, thank you.
So next is also mine only.
Okay. Next section by the same presenter.
Okay, you can start.
My topic is laparoscopic management of UPJ obstruction with stones in children. UPJ obstruction is a common congenital anomaly of the ureter. For the past decades, open pyeloplasty has been considered as gold standard treatment. But nowadays, minimally invasive procedures have replaced open surgery, but the association of secondary lithiasis could complicate the procedures. Traditionally, it was believed that urinary stasis and infection were the cause of increased incidence of nephrolithiasis in patients with UPJ obstruction. We report our experience of concomitant laparoscopic management of UPJ obstruction with stones in children. It was a study, and again conducted over 15 years, in which 11 children who underwent laparoscopic pyeloplasty along with removal of stones, secondary renal stones. Their diagnosis was based on the basis of history, physical examination, renal sonography, intravenous urography, and descriptive analysis was made. Surgical technique which was followed was the renal pelvis was opened to extract the calculi. The procedure of removal of stone depend on the size and location and number of the stones. In some cases, stones were picked up by using laparoscopic grasping instruments. In other cases, it was removed using a flexible cystoscope. And in some cases, there were small multiple calculi. Saline wash was given using infant feeding tube. And then the pyeloplasty was completed. It's just showing a case where a stone and multiple calculi and stones are showing in the right lower calyx, along with contrast CT, which is showing dilated pelvic ileal system. The most common mode of presentation was pain abdomen, hematuria, recurrent UTI, and fever. The size of the stone varied from 3 to 11 mm. These were the different methods by which I've already told, stones were retrieved according to these methods, either by pelvic wash or using a laparoscopic grasper, using flexible nephroscope or a rigid nephroscopy. So according to my results, laparoscopic manipulation and extraction of stone added a mean time of 18 minutes, and the mean total operating time was 109 minutes. None of the children has excessive bleeding. None of the children had major post-operative complications, and radionuclide renogram was done 3 months following surgery, which showed good drainage. Here's a case which I already showed with a DJ stent and renogram showing good drainage. So coming to discussion part, uretropelvic junction obstruction is a common anomaly, but controversies exist regarding stone formation and management in these patients. Concomitant occurrence of stone is not uncommon. Prevalence of stones in a patient with UPJ have been described higher than in general population. And, various studies have been done to support this evidence. In study by Mayo Clinic, in which 1,600 patients participated, showed 70-fold increase in patients with having uretropelvic junction obstruction along with stones. Same was shown by David and Langwood and Lempet et al. Shown at least 14% of patients were having concomitant stones along with UPJ. It was hypothesized earlier that delayed drainage due to UPJ result in crystal agglomeration and nucleation, but controversies exist whether they have any underlying metabolic causative factor as well as anatomical condition also. It is a well-known fact that urinary stasis alone does not appear to be sole contributor of the lithiasis in horseshoe kidneys, and urinary infection and metabolic factors also play an important role. Current evidence shows combination of factors that could be responsible. It could be undiagnosed metabolic abnormality, pH values. Same has been shown by Hussain et al., in which it was reviewed in pyeloplasty along with simultaneous stone removal, showed a significant percentage of study group in which further stone analysis was done and infections through white stones were found. In 36 patients, they were presented with increased concentration of several known lithogenic substances, which were hypercalciuria, hyperoxaluria, hyperuricosuria, or hypocysturia. Metabolic evaluation done subsequently in this group revealed 83% has already having an underlying abnormality, and medical management treatment arm yielded only 17% stone recurrence. Long-term antibiotic treatment was followed in these cases. According to these studies, the author concluded that laparoscopic and robotic pyeloplasty with concomitant stone removal was a safe procedure. They recommended that minimally invasive pyeloplasty should be constituted the first choice of treatment for concomitant renal stones. Coming to the conclusion, same thing, laparoscopic pyeloplasty with simultaneous extraction of renal stone is a feasible, safe, and promising solution to tackle both the problems. Thank you.
Achha, Doctor, just tell me that PUJ was primary or that are due to the stone only?
Sorry?
In your study group, that PUJ was primary or due to the stone?
Sir, in 11 cases, 3 cases were primary PUJ, rest were due to stone was also there.
Then in that case, why you did pyeloplasty? In that case, why you did pyeloplasty?
Sir, along with the stone extraction also, on CT renogram, it was showing a contracted part. So we have to remove that, and along with that, we have done stone retrieval also.
Can't comment on the picture that also stone is there. Even in the radiograph, whether you are speaking radiograph or you are DTP, because you have objective fact, you can't do it now.
No, in only.
Then you can only evaluate the picture and all that.
Yes, yes.
Even if you see there is some negative starting is there.
Yes.
That can't be definitely that there is a key.
Yes.
So you should rule out whether it's a secondary or primary. You know it's a secondary.
Then no point in doing. Yes, I agree.
How did you follow up this case and for how long duration?
Sir, first it was renogram was done follow-up for 3 months, and patient will follow up to 2 years.
There was no stone recurrence.
In some cases, stone recurrence was there. In approximately data is there. Approximately 40% of cases, stone recurrence was there.
40%.
Yes.
What was the cause of that recurrence?
Metabolic abnormalities.
So did the metabolic?
That was my next question. Have you done metabolic analysis?
Yes, we have done. So we have sent
For all the patients?
Not for all the patients. The past, which were like from 2005 to 2010, it was not done. But recently cases we had been doing metabolic autopsy.
Yeah, what is the metabolic protocol for the means stone evaluation in children?
Sir?
What is the metabolic protocol? Metabolic evaluation protocol in children? You were saying that you did metabolic evaluation in, I think, two patients. What was the?
All your patients were children, right?
Yes, sir.
Then what was the specific protocol, if any, for metabolic evaluation in children? That's what Dr. Sanjay is asking.
And which parameter you included in the evaluation? You did the study. You are already saying you did the metabolic evaluation. Oh.
Thank you. Our first speaker, first presenter is actually arrived. So, Dr. Ankur Arya, please come on the dais.
So good afternoon, chairpersons, respected seniors and colleagues. Please make it visible. So I'll just show you one case presentation that we came across. It is about the posterolateral polyp, which is not so common as a cause of lower urinary tract obstruction in an infant. So 11-month male child presented with a history of excessive crying and straining while passing urine since 4 to 5 days. He was catheterized outside in view of urinary retention. And when patient came to us, he was having little fever and the patient was started on antibiotic. Child was stabilized. There's no previous history of UTI retention. Investigation, urine culture was tried in the follow-up, and serum creatinine was absolutely normal, that is 0.6. Ultrasound further revealed small right kidney with right hydroureteronephrosis, and there's a feature of cystitis in form of thickening of the bladder. Radionuclide scan, that MAC3 scan was done. It was showing the 10% differential on the right side, just suggestive of poorly functioning right kidney. MCU micturating cystoarthrogram revealed dilated posterior urethra, and there is a filling defect, as we can see here. So this is a short video. So there is a grade 5 reflux in the kidney on MCU, and there is a filling defect, as we can show by the yellow arrow. So on cystoscopy in the posterior urethra, we see there is a mass that is attached to the proximal aspect of the veru, and there is a huge diverticulum near the site of the right ureteric orifice. There is a mass with the overlying calcification. So we have done the piecemeal resection by 11 French resectoscope and the loop. One should be careful while resecting this mass, because detaching it from the base will create a difficulty in retrieving this mass through a narrow urethra, small urethra. So this is the complete picture after fulguration of the site of the attachment. So patient became symptom-free, visual uroflowmetry pattern returned to normal following the resection. Histopathology revealed fibroepithelial polyp that is covered by the transitional epithelium. Oral antibiotic was given according to the urine culture as child developed UTI 1 week after the surgery. And patient is still on low dose antibiotic prophylaxis because he is having grade 5 reflux. So now it is almost 3 months after the surgery. So we are planning to do a repeat radionuclide scan in a follow-up, maybe after 2 to 3 months, but child is doing fine. There's no element of any UTI on low dose antibiotic prophylaxis. So these are the rare congenital entity, though some, there are cases, 50 odd cases are there in the literature, and they are rare as compared to the other known entity that is posterior urethral wall. Symptom that intermittent retention of the urine, dysuria, hematuria, and the various theory have been put for the development of this fibroepithelial polyp, that is invagination process of the submucosal glandular material of the inner zone of the prostate. There is a developmental error. Sometimes due to the effect of maternal estrogen, there could be abnormal growth, and it thought to be remnant of the Mullerian tubercle, that is a mesonephric duct. So they used to have another tract, upper tract anomalies in the form of vesicoureteric reflux, could be having a hypospadias, bladder diverticulum. Diagnosis, the gold standard is a micturating cystourethrogram supplemented by the urethrocystoscopy. The treatment options, definitely there is a challenge while managing it transurethry due to the small urethra. But even if the mass is big, we can retrieve it out by doing a Bugbee electrode, detaching it from the base by a Bugbee electrode. But in that case, we may require transvesical approach just to retrieve out the specimen. So combined transurethral and transvesical approach is necessary if the mass is big and if we are not careful while doing a piecemeal resection. The differential, it could be a polyp of Boteroid sarcoma, that is leiomyosarcoma of the bladder and the wall. But one good thing about the posturethral polyp is, as compared to the posturethral wall, there is a long-term impact on the bladder is very minimal. But definitely this patient is having a grade 5 reflux, so child should be kept under observation to prevent further deterioration. And we may have to, and the counseling of the parents are very important, so that they will be in a follow-up. They should not think by doing a resection, everything will be all right. So they should be in a long-term follow-up. So it must be considered as one of the differential for causing lower urinary tract obstruction in a child. Urethrocystoscope is both the diagnostic and the therapeutic. And these are the benign congenital masses, but the sequelae of these masses in the form of bladder dysfunction and the upper tract dilatation with deterioration of the renal function should be kept in the mind. Thank you.
Fibroepithelial polyp is your observational finding, your gross finding, or that is the histological finding?
No, posturethral polyp we have kept as a diagnosis.
No, but you have told in the histological.
That is the histological finding, fibroepithelial polyp.
Then how do you report it as a polyp? In the histological.
No, polypoidal, see, if we can see some growth, that is a polypoidal attached with a narrow base.
That's okay.
Yes.
That's your observational finding. On the basis of the histology, how can you say it is a polyp?
See, fibroepithelial polyp, there is a tissue that is lined by the transitional epithelium. So histopathologically, there is a well-defined criteria to call it as a fibroepithelial polyp, because there was a calcification at the top of the mass also. So we thought it could be some malignancy. But later on, after talking with the histopathologist, they told me it seems to be a benign entity. So they can see some muscle fiber there, but it is covered by the transitional epithelium and there is no malignant degeneration in the given specimen.
Transitional epithelium covering is now the criteria for the polyp.
Because there is no mitotic figure. See, if I am saying benign, that I mean to say there is no increase in the mitotic figure there. There is no atypical nuclei there. So all the finding that is in the favor of the benign mass was there. So that is a diagnosis. Because historically, if you see all the cases, they have mentioned it is covered by the transitional epithelium. Some muscle mass you can get there near the bladder neck area, but there is no malignant degeneration in the form of necrosis, increase in the mitotic figure. Like if it is a leiomyosarcoma, as I told you in the differential diagnosis, it should be having a derangement of the muscle fiber in the leiomyosarcoma and will increase in the atypical nuclei and the increase in the mitotic figures. So that is not a case here. It is a pure benign mass that is covered by a epithelium.
about this. Actually, your comment was not understood by him.
Because I mean to say, I am correlating it cystoscopically and histopathologically.
Yes.
Because you can't diagnose it by any other mean. Because I have to prove it. If I am thinking it is a benign mass, so it should be supplemented by some histopathological finding. So histopathologically, there is no as such criteria to call it as a leiomyosarcoma or something else. That's why I'm calling it. That's why they have given me the diagnosis of a benign polyp.
No, we have not understood your comment. I'm sorry for that. What
sir.
was your actual comment on this?
No, sir, on the basis of the histopathology, polyp is a gross finding.
Yeah. So
And
we
the
are only presenting
fibroepithelial
as
is a
it's a
histopathological
clinical,
finding.
it's a clinical presentation as a polyp. And once you do that, thereafter when you get the histopathology, the final report is brought to the screen. Yeah, ultimately it came out to be like this. Whether it is benign, it is malignant, or anything unusual. What I want to tell about this is, if you see can you project that this picture? It's a very classical picture. You will hardly find this picture anywhere. It's a bookish picture. If it's given to the residents, they will be asked 10 questions as to what is this. So first thing they will say it is a posterior urethral valve. But the posterior urethral valve picture is entirely different. You on radiologically, you can, if it is gross changes, you can easily see the posterior urethral valve, you can see bladder neck hypertrophy, you can see, and associated changes you can see. In this case, you find there is something. In the beginning, we also didn't realize as to what it is. We also thought it will be posterior urethral valves. And then when we went inside, it was a surprise for us. And for a urologist, I have spent a lot of time in urology. Even for me, it was a surprise to tackle this case. Later, when I discussed with one of my colleagues who is a pediatric surgeon, he said he's published 3 cases in Indian Journal of Urology. It is so rare it is.
So my purpose is just to apprise you because it is not such a common entity as the posterior wall. That's all. Thank you.
One more question. One more question. How are you planning to follow up this case actually?
See, we will concern about the bladder function in this patient and the upper tract because there is a differential function is less than 10%. But in the child, we used to keep a criteria that we should give a chance. We are not contemplating any surgery regarding the right poorly functioning kidney, but we have to keep this patient by doing a radionuclide scan maybe after 6 months of the surgery. So it is almost now 3 months. After 3 months, we will do the again max scan just to see how much is the improvement. And still, if there is no improvement, we can keep this child on a prophylaxis till 4 to 5 years of the age. And we can follow up with the MCU also, maybe radionuclide DRCG or the MCU, just to see how much is the resolution, though the chances are very remote. But I will apprise the family about the further deterioration and he may require nephrectomy, definitely. And maybe as the child will grow, I have to keep a watch on the KFTs. It should not increase. And bladder function evaluation, maybe I will do the filling cystometry, that is at the later stage.
Are you considering any investigation like MCU or uroflowmetry because you have resected in the urethra?
As I mentioned, we used to see the visual uroflow actually, because it is very difficult in a small child, 11-month child.
No, in the follow-up period when the child will get
Yes,
older.
definitely. We'll evaluate the uroflowmetry pattern also. When the child is able to hold the urine so that we can evaluate, there should not be any stricture. Though I have resected it, there is no damage to the surrounding area, surrounding epithelium. It is just detachment from the proximal veru. And one should be careful not to damage the ejaculatory duct also, because it's just exactly open there. So I will definitely follow the patient with the uroflowmetry, counsel the patient relatives about the evolution of any obstructive urinary symptoms. So we have to keep a watch on all this.
One more question.
Yes.
Actually, it's you have looked in the literature previously published for this entity. The origin of this tissue is actually quite debatable.
Yes. That's why there are the multiple theories.
Yeah, you have mentioned that. So just for knowledge, did your histopathologist suggest any particular, whether it's Mullerian duct remnant, or can you enlighten us? Or
no, in this particular thing, they have not mentioned, they have not seen the structure like that, but because it is just theory. You
Because
can't
it's
rule it
very
out
rare.
the Mullerian duct origin by just seeing on the histopathology all the time, because you are resecting the tissue. Sometime with the resection loop also, there is some tearing of the tissue. Because initially when I talked with the histopathologist, they were not aware what is exactly the specimen is. We told them that the specimen from the urethra, they were thinking it is from the bladder. So I told them it is from the urethra, it is a polypoidal growth. Then again they review the specimen, then they told me it is a benign specimen and there is some covering of the transitional epithelium over there. But apart from that, they are not able to identify any tissue in that.
Okay. In this case, there is a calcification inside the.
Yes, yes. That's why we thought it could be something malignant. But yeah, definitely on the top of the growth, you can see some calcification was there. But histopathologically, it was absolutely benign. So that was a huge sigh of relief for us because as a small child, we are very worried. If some malignancy is there, then really it matters.
Thank you. Any question from the house? Thank you.
Thank you.
Next presenter is Dr. Kartikeya Atre.
Good afternoon, everyone. I'll be presenting a paper on outcomes of high-grade blunt renal trauma at our center in Belgaum. The majority of blunt renal traumas occur due to either motor vehicle accidents, fall from heights, or assaults. They account for 80 to 90% of all renal injuries, whereas penetrating trauma is far less common. The most widely accepted classification is that of the AAST. And majority of these traumas, when graded in this classification, are minor, that is grade 1 and 2, and heal spontaneously without any much intervention. It has been validated in multiple series as a predictive tool for clinical outcomes and to predict whether surgery is needed or any other intervention is needed, and even to predict the rate of nephrectomy. According to the new guidelines, which were published in 2018, grade 4 injuries now include vascular injuries such as AV malformations and pseudoaneurysms, and grade 5 also include devascularized kidneys with visible active bleeding and a shattered kidney with loss of identifiable renal parenchyma. The standard of care in hemodynamically stable, well-staged patients with AAST grades 1 to 3 is conservative, that is non-operative, regardless of the mechanism of injury. Conservative management has also proven to be good in even higher grade traumas. It has not been associated with any increased length of hospital stay and even may give a shorter length of stay. They are obviously associated with higher renal preservation rates. The objective of our study was therefore to analyze the management and short-term outcome of high-grade blunt renal trauma presenting to our tertiary care center. This was a prospective observational study conducted between January 2016 to December 2020. The following were the inclusion criteria. We included patients with only high-grade blunt renal trauma and those who were greater than 18 years of age. These were all consenting patients. Computed CT findings were used to grade the renal injuries and other abdominal injuries, and AAST scaling was used to grade. Management, what we followed was divided into 3 categories. Expectant management, which did not involve much to be done from the doctor's side. It was more about observation and serial imaging. Conservative or minimally invasive management included the help of an interventional radiologist, maybe endoscopic procedure or percutaneous procedure. And open operative management was either partial nephrectomy, rhinorrhaphy, or total nephrectomy. We can see, comparing the patients at presentation, patients with grade 5 renal trauma had significantly lower systolic BP, significantly lower hemoglobin, and more rates of concomitant abdominal injuries as compared to those presenting with grade 4 renal trauma. Mean age of our patients was 35 years and more males were involved. The most common cause for the blunt renal trauma was road traffic accident. We had a total of 78 patients, out of which 50 were grade 4 and 28 were grade 5. 38 patients with high-grade renal trauma had concomitant abdominal organ injuries, and the most commonly involved organ was the liver. 78 patients in the beginning were all admitted and started on expectant management with intravenous fluids, bed rest, and serial hemoglobin checks. 40 patients, that is around 51% of the patients, needed blood transfusion, and 20% needed platelets transfusion within the first 24 hours. Renal angiography with angioembolization was done in 12 patients, out of which 9 belonged to grade 4 and 3 belonged to grade 5. The indication for this was persistent low systolic blood pressure in spite of adequate transfusion and resuscitative measures. These are the management protocols that we followed. We can see expectant management was more common in grade 4 as compared to grade 5, and the rate of nephrectomy was more common in grade 5 as compared to grade 4. Other management lines were conservative management, that is renal angioembolization, ureteric stenting, rhinorrhaphy. We can see the hospital stay was more in grade 5 patients. However, it was statistically insignificant. This is one renal angiography, and it is the figure B showing the site of bleeding with the yellow arrow. And 1C, we have taken the help of a interventional radiologist and helped with the embolization. The bleeding stopped and blood pressure was maintained in all of these patients. 2 patients of grade 4 had UPJ obstruction with grade 4 injury and renal collecting duct system injury. Both underwent cystoscopy, evacuation of blood clots from the bladder, and degestenting. Nephrectomy was performed in 3 patients with grade 4 injuries and 6 patients with grade 5 injuries, as already mentioned. We saw complete hilar disconnection in 5 patients, main renal artery disconnection in 1 patient, massively bleeding shattered kidney in 3 patients. 5 of the 78 patients expired due to multiple injuries, massive bleeding, and concomitant head injuries. This is a CT which was done on the figure A, and B was done on the day of the injury. We were following up our patients with the serial CTs to be done 48 to 72 hours after the day of admission. And if there was no signs of any expanding hematoma, we were still continuing with the expectant line of management. Similarly, this is a CT of a patient 33 years old with grade 4 renal trauma. Even in this, in figure C and D, we can see that there is no increase in size of hematoma. And even after 1 month, when we followed up this patient with only expectant management, it shows good perfusion to the kidney. And this is one specimen who had to undergo total nephrectomy. Current standard of care for low-grade renal trauma has been conservative or expectant. However, now it is also recommended for most high-grade injuries. When patients are hemodynamically stable, CCT with immediate and delayed imaging is the best method of GU imaging. Using contrast-enhanced CT can easily detect fine anatomic details as the most serious injuries and has improved the confidence as to which injuries can be managed non-operatively. These are the findings which we have to take care of while evaluating a patient. The newer modalities of treatment like arteriography and embolization have also been commonly used for management of high-grade renal traumas, thereby preventing the rate of nephrectomies. Other modalities include super selective embolization therapies. And even if none of these modalities come in handy, then the surgical option should be followed. Routine follow-up CT imaging is recommended from 48 to 72 hours. And any hemodynamic instability, devascularized kidney, pedicle avulsion, or UPJ avulsion is an absolute indication for surgery. In our study, 66% of patients with grade 4 renal traumas and 53% with grade 5 could be given expectant management, and therefore it should be conserved. It should be considered so as to have high preservation rates.
Okay. Doctor,
thank you, sir.
Just tell me the mortality rate was higher in which group? That was
Mortality rate was higher in grade 5, sir, because
that was managed by surgery, or that was by on the conservative management.
Sir, out of the 5 patients that died, 3 of them had died before we could perform any intervention because of severe blood loss preoperatively.
What was the outcome of conservative group?
Sir, in conservative group, we didn't have to re-explore any patient. All the patients who we took up with conservative management performed well.
All doing well.
Yes, sir. No conversion to surgery had to be done.
So there was no any history of the septicemia or like that.
No, sir. No post-op. At 1 month of follow-up, most of them were all right. No septicemia or.
Do you follow any kidney function of that side?
We did DTPA cancer and angiography to see for the vascular status. And as mentioned in the study, I just showed a picture. Even after 1 month, post 1 month of follow-up, we could see good vascularization in the post-op.
No, how much was the kidney function of that?
Sir?
How much was the kidney function of that side?
Sir, around 60%, 66%.
No, that injured part.
Out of the, sir, what we achieved was that the upper 2/3 was well vascularized, whereas the lower pole we could not achieve adequate vascularity.
You have done DTPA in the follow-up period.
Sir,
Have you done or not?
yes, sir, in patients. At least we have done vascular imaging, sir. DTPA, I'm not.
What is the longest follow-up period?
Up to 1 month, sir.
1 month is the longest follow-up period.
Yes, sir, because severe trauma after that post-op in nephrectomy patients, even after 1 month, there was no active management to be done.
No,
And
that's okay, but how will follow the functional status of that kidney?
using RFT, sir, serum creatinine and
No.
Any patient of your observation group developed hypertension?
Post-op hypertension, sir, no case was reported with us.
No, not post-op only.
Even
in the conservative
due
group
to
also.
deteriorating renal function, no case of hypertension
But
was
your
reported
maximum
to us.
follow-up period is actually 1 month.
Yes, sir.
So many patients are reported having hypertension and uncontrolled blood pressure actually years after that. Page kidney. Any question from the house? Thank you. I think we should conclude the session.